Two columns and two rows. So it goes here.
Hi, Dr. Rekha. How are you? Good evening, Sarita ma'am.
Hello, madam. Good evening. I'm just trying to make my video on.
Uh,
Yeah, very good evening. Very good evening.
how are you,
Hello,
ma'am?
Dr. All well, Dr. Monica. What about you?
Ma'am, good, good.
So I'm the
It's
second person to join. Maybe many more are joined here.
because in 2 or 3 minutes, many people will join.
Yeah. So you had this faculty link separate, no?
Ah,
Hmm.
because we
So
have got very large number of faculties, 9 chairpersons, 10 panelists, 2 expert panelists, 3 speakers, 5 coordinators, chief guest, guest of honor. So a long list of person will join.
that is the beauty of webinar, you know.
Ah.
Many
Good
person can
evening,
get
Sarita ma'am,
together.
मोनिका मैम।
हेलो संगीता
Hello,
जी,
Dr.
नमस्ते
Sangeeta.
नमस्ते, कैसी हैं?
मैं अच्छी हूँ,
ऐसा
आप
लग रहा है
कैसे
कहीं
हैं? अभी
सीट
देखा
ईस्ट में
मैंने कहा
बैठ करके टॉक देने वाली हो डियर.
माय प्लेजर एंड
You're not looking like it as a speaker. Yes, like something will have a fun. Nice to see your
आपको देख के
background.
तो फन कैसे आएगा? आपको देख के सो नाइस है। सॉरी,
So I think I should wait.
And in just 2 or 3 minutes, sir will join.
Yeah, I'll mute by that time, right?
Very good evening, Abha ma'am. I just noticed ma'am has joined.
हाय डॉक्टर
आभा सिंह मैम।
अर्चना। हेलो आभा मैम, कैसे हैं आप?
Good evening, Abha ma'am. So nice to see you.
Available. Thank you for support for this. Gurugram.
Sarita ma'am, good evening. Tabassum ma'am, good evening. Ava
Good
ma'am, good
evening,
evening.
Monica ma'am. Hi, this is Sangeeta here. Hi.
Good evening, ma'am.
Good evening.
Monica Gupta ma'am, good evening.
गुड इवनिंग। मैंने तो आपको हाय किया।
नहीं, मेरा वीडियो मैंने देखा नहीं, ऊपर मैं तो नीचे
हाँ
वाली लिस्ट देख रही थी।
हाँ, मैं भी वही कर रही हूँ।
मैंने जो 3 सीरीज नहीं थे मैम, वो तो
हेलो,
मैंने
हाँ
अभी
मैं
ग्रुप
वही
पे
देख
डाले हैं।
हाँ
हम्म मैं फोन करना शुरू करती हूँ मैम, 2 मिनट दीजिए। आभा मैम तो है, सरिता मैडम भी है, तृप्ति मैडम नहीं दिख रहे मैम मुझे।
there.
हेलो,
Good evening, Ava ma'am. Good evening, Dr. Monica.
Good evening, Monica. Good evening. Good evening, Rashmi.
Hello.
गुड इवनिंग
गुड
आभा
इवनिंग
मैम।
मैम।
Good evening, Monica Square.
थैंक यू मैम, गुड इवनिंग। सो मेनी मोनिकास देयर।
Yeah.
Good evening, ma'am.
Good evening.
मैम,
Namaste,
आभा
Singh
मैडम,
ma'am.
गुड इवनिंग।
Good evening. Good evening.
नमस्ते आशा मैम, कैसे हैं?
Namaste ji, bilkul बढ़िया.
Good evening,
आशा
ma'am.
मैम, गुड
Asha ma'am,
इवनिंग।
good evening. Abha ma'am, good
नमस्ते,
evening. Hi, Rashmi.
नमस्ते.
Namaste,
Hi.
ma'am.
आज के दोनों स्पीकर्स को मेरा तहे दिल से धन्यवाद. संगीता एंड तबस्सुम. थैंक यू, थैंक यू, थैंक यू.
My pleasure, ma'am. You gave me this opportunity.
Good evening. Thank you, ma'am.
हाय डॉक्टर तबस्सुम, कैसे हैं?
बढ़िया, आप कैसे हैं मोनिका
बस
मैडम?
बढ़िया। ऑनलाइन मिल जाते हैं, दिख जाते हैं।
हाँ.
आशा मैम, डॉक्टर तृप्ति हैजंट जॉइंड। एक बार उनको फोन कर सकते हैं, बाकी सब तो मुझे दिख रहे हैं मैम। सर को भी मैंने फोन किया, सर इज ज्वाइनिंग इन अ मिनट्स टाइम।
Good evening, Abha Singh ma'am.
Good evening, Tabassum. All set?
बस बस।
Yes, ma'am.
Hello, Dr. Tabassum.
Hello, ma'am. Hello. Nice to see everyone today.
तृप्ति मैम इज नॉट देयर, नो?
That's why I'm saying, ma'am. Tripti ma'am has not joined. Rest I can see at least first session और inauguration के तो सारे हैं मैम बाकी।
तो शुड आई कॉल तृप्ति मैम?
आशा मैम is calling, I think, मैम।
ओके ओके ओके, ठीक है। सर हैज आल्सो जॉइंड। नमस्ते
Yeah.
सर।
Good evening,
Namaste.
sir.
Good evening. Good
Good
evening.
evening, sir.
Sir.
Namaste, sir.
evening.
Good evening.
Namaskar.
Namaste.
Good evening,
evening.
sir. Namaste.
हाय दीपिका।
Yeah, hi. Good evening, sir. Hi, Dr.
Good
Monica.
evening, Patel sir.
Good evening, ma'am.
Good evening.
Good evening, sir.
સર બાકીના બધા આવ્યા છે, ચીફ ગેસ્ટ બી છે, તો કેન વી
Oh, yes,
સ્ટાર્ટ
we
વિથ
can
ધ
start.
વેબિનાર? યસ,
Yes, we can start.
ઓકે સર. કાર્તિક, પ્લીઝ give me the countdown once you're live. કાર્તિક,
हाय रेखा, कैसे हो?
गुड इवनिंग। मैं अच्छी हूँ मैम।
Mayur is there. Mayur, please give us the countdown so that I can start with the introduction.
Madam,
Good
good
evening.
evening, Patel sir. Good evening.
Yes,
Thank
good
you so
evening,
much
good
for
evening.
inviting me. Thank you.
Yes, very good evening.
Madam, I can see only on the webinars nowadays.
Yeah, I was
Mayur,
out of station.
मैडम ठीक है, आप कैसे हैं?
हाँ, मैं अच्छी हूँ। तुम कैसी हो सरिता?
ऑल वेल मैडम, ठीक हूँ, बस आपका आशीर्वाद है.
Yeah, so good evening, all the faculty members. We are ready. So just tell me when to start so I can
yeah, just start.
change
Just
slides.
start the recording. I will introduce everybody. Okay.
Okay, ma'am.
Yeah. Are we good to go? Can I start?
Yes, ma'am.
Yeah. A very good evening to all the August gathering with esteemed faculty members and delegates who have joined us for the 218th episode of the Masterclass of Happy Learning webinar series. This series is in association with Bhilai, Bilaspur, Raigad, Raipur, Rewa, and Singrauli societies. And today's theme is very, very important. It deals with bleeding and pregnancy. So we will be having our speakers who will be covering bleeding during the first, second, and third trimesters in detail, and which will be followed by a panel discussion, case-based regarding the same. The brainchild of this webinar series is none other than Dr. MC Patel, sir. Sir, thank you from all the coordinators and myself for giving us an opportunity to coordinate this webinar in association with such esteemed faculty members. Let us begin this webinar with the blessings of Lord Almighty. Can we have the inauguration slide, please? Mayur, inauguration slide, please. There's no audio. Mayur.
Yes, ma'am.
Audio is not there.
Audio is not there.
Yeah. Thank you, Mayur. Now it is my proud privilege to introduce our program director, Dr. MC Patel, sir. Sir officially has been the past vice president of Foxy. He has been the president of the Ahmedabad OBGYN Society and president of IMA Ahmedabad and an active member who has been operating in the Northeast since the last 33 years. And currently also he has been just back from Arunachal Pradesh. The three words that I can describe Dr. Patel sir is patience, perseverance, and passion for teaching, because he has been continuously doing this series since the time COVID, because he wanted academics to reach every nook and corner, even when COVID had struck us. Sir, we welcome you on this platform to welcome the August gathering.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all to one more episode from Happy Learning Masterclass. And as mentioned, today's joining society Bhilai, Bilaspur, Raigad, Raipur, Rewa, and Singrauli. I welcome Dr. Abha Singh Madam, who has kindly consented to be chief guest. Of course, she is always with me in any of my academic activity. Thank you, Madam, for always to be with us
Thank
in
you
academic
for
activity.
remembering. Yeah.
Yes, and thank you for sparing time to bless us. I also welcome Dr. Sarita Agarwal, who has kindly consented to be guest of honor. We have worked together in Foxy since long, and Sarita is also very much kind to me. Whenever I have called her, she is always ready to be with me in any of my activity. So welcome, Dr. Sarita, for sparing time. I also welcome Dr. Trupti Nagaria, Madam. she's busy with some work at college, so she told me that she may join little later. So in her absence, I welcome her also. I also learned chairperson, Dr. Archana Chauhan madam from Bhilai, Dr. Padma Shukla from Riva, and Dr. Geetika Sharma from Bilaspur. They are going to chair very interesting session, bleeding during first and second trimester, which to be dealt with by Dr. Sangeeta Sharma madam from Bilaspur. I also welcome one more set of chairperson, Dr. Jyoti Jaiswal madam from Raipur, Dr. Paulomi from Raipur, Dr. Rasmi Sharma from Bilaspur, and they are going to uh, 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 chair one more interesting session, bleeding during third trimester, and Dr. Tabassum has kindly consented to deliver the talk. I also thank very specially to Dr. Tabassum to help us in an emergency. She has kindly consented to deliver this talk. I also welcome one more set of chairperson, Dr. Mahesh Prasad from Singrauli, Dr. Tribhuvan Sahu from Raigad, Dr. Rekha Singhal madam from Riva. They are going to chair one more interesting session, legal issues in obstetric hemorrhage, which is to be dealt by me only. I also welcome Dr. Asha Jain. She was convener for this series for years together, and today she has kindly consented to be moderator to discuss very interesting real happen cases and case-based scenario in bleeding during pregnancy. I also welcome two learned experts, Dr. Meena Armo from Rajnandgaon and Dr. Salini Jain from Raipur. They will have their expert comments during panel. I also welcome all the learned panelists, Dr. Anjana Chaudhary madam from Anjana Chauhan madam from Bhilai, Dr. Monika Pathak from Raipur, Dr. Jofi madam from Raipur, Dr. Prabdeep Kaur madam from Bhilai, Dr. Anusri from Bilaspur, Dr. Anuradha from Raipur, Dr. Rasmi Sood from Raipur, Dr. Sunita Kanoi from Raipur, Dr. Ankita Agarwal from Ambikapur, Dr. Neha Thakur from Mahasamand, Dr. Saurabh Birthare from Korba, Raipur, Dr. Rupali Verma from Raipur, and Dr. Kirti madam from Raigad, and all the president and secretary of respective society who have joined this webinar, and all the delegates. As mentioned prior, so in era of COVID, when we were unable to meet each other, I started this series, and at that time goal was just to meet our Foxian friends, to say hello and to update our knowledge for a very focused topic. And the same way today we are going to discuss bleeding during pregnancy. So ultimate goal was to check maternal mortality and infant mortality rate, because by 2030 WHO and Government of India has given us a target, then maternal mortality rate should be less than 67 and infant mortality rate should be less than 12. And of course, there are few states in southern India, they are having MMR near 30. But at the same time, there are few states in northeast particular area, their mortality rate is still near 200, and it's a matter of concern for us as an obstetrician. So it is a joint venture, government, federation like Foxy, IMA, and all the obstetrician friends or any other doctor who deals with delivery and pregnancy related any problem in remote India. And if we go hand in together, then we can check this maternal mortality rate and we can reach the goal given by government. So with this goal, we are discussing this type of topic every Tuesday, 6 p.m. under banner of Happy Learning Masterclass web series. So without wasting much of your time, welcoming you all to one more episode of Happy Learning Masterclass. Thank you. Thank you very much.
Thank you, sir. It is always an honor to listen to your topics, the medical legal aspects. You have been guiding all the gynecologists across India through various medical legal aspects also. Now it is our turn to Thank all our coordinators, Dr. Monica Gupta Madam from Alwar, Dr. Deepika Madam from Delhi, Dr. Shatabdi Dey from Shiliguri, Dr. Nivedita Datta from Bokaro Society, and Dr. Megha Kamlapurkar from Kalaburgi or Gulbarga Society. I have an honor to introduce our chief guest, Dr. Abha Singh Madam now. Dr. Abha Madam's CV, please. Madam has been the Vice President of the Society of Vaginal Surgeons India. She is also the present President of AOGCG, the patron of the Raipur Obijwai Society, IMS Raipur also, the past President of Raipur Obijwai Society, IMS Raipur. She has been awarded the prestigious CM Trophy for the Meritorious Service in 2002, Padma Shri S.K. Mukherjee Award in 2005, the Rashtriya Gaurav Award in 2009, the Best Paper in Oncology in 2013, the Health Icon of CG by Times of India in 2016. She has been the ex-dean of the Pandit Jawaharlal Nehru Medical College at Raipur, the ex-vice chancellor at Deen Dayal University of Medical Sciences. She has presented more than 110 papers and written more than 80 articles in index journals. She has conducted various life workshops in NDVH, colposcopy, program labor, the uterine artery ligation, Wheelan suture techniques for the postpartum hemorrhage. We welcome you, ma'am, and we invite you for a few words of wisdom. Thank you for honoring our invitation for being with us today.
Thank you, Monica, and thank you, Patel sir, for inviting me. I mean, there is no other person or no other name that comes to my mind when you are talking of organizing CMEs as webinars. So this is congratulations. This is 218th episode, and I really heartily appreciate all your efforts and your time that you, as well as the whole team, the convener, the coordinators, they put into this and make it possible for us to learn and to keep brushing up the very basic topics. Like today's topic, it is about the bleeding in pregnancy. Though it is very common, but still it can be sometimes, it can be just a normal bleeding without any effect on the pregnancy, or it can be sometimes life-threatening. It may be associated with some placental abnormalities or prematurity and low birth weight and all these things. So it's always very nice to brush it up and to understand that how to intervene and in what way to intervene. As you already said, that we have to reduce the maternal mortality, and hemorrhage is one of the very, very common causes of maternal mortality. So it's a pleasure to be present here, and I'm really waiting to listen to the lectures. Thank you so much for having me here.
Thank you, madam, for sparing time for us. Thank you.
Thank you, ma'am, for your kind words of wisdom. I now invite Dr. Monica Gupta Madam to introduce our guest of honor, Dr. Sarita Agarwal Madam and Dr. Tripti Nagaria Ma'am today.
Thank you,
Over
Monica
to you,
and
ma'am.
Patel sir,
Yes,
for
ma'am.
giving me opportunity to be a part of this prestigious webinar. I'm really feeling very proud to be a part of the webinar who is just going to cross 250 now in few days. And today our guest of honor are Dr. Sarita Agarwal ma'am and Dr. Tripti Nagaria madam. Dr. Sarita Agarwal madam is a professor and HOD of OBGY in AIMS Raipur. She's a past VP Foxy, and she is holding a dean position for the research purpose in the academic session. She is a principal investigator who is doing many research projects done by the even by the ICMR. And she has started with a unique program of bed yoga program in which she assists postnatal women in recovery through specialized movement and relaxation exercise techniques. And we look forward to you, ma'am, ki one day you can make us also learn this type of techniques. And she has a vast clinical experience and teaching experience of 33 years and her special interest into the field of obstetric and gynae. Thank you, madam. Over to you for your words of blessings.
Thank you, Dr. Monica, for your kind words. Yeah, the respected Madam Abha Singh Madam, who is a mentor, who is in a, vision ahead to see her, like, I want to become like her, Madam. So great of you for mentoring me and reach this position. Dr. M.C. Patel, sir, colleague in Foxy, senior, but very friendly. And as Monica said, his pursuance, passions to teaching is really remarkable. I also endorse that. एंड मेडिको लीगल की कोई बात आई प्रॉब्लम आई तो एमसी पटेल सर हमेशा हाजिर हैं he doesn't look into that ki whether the person is going to do something good for him or not. He is always ready. That is I like the most, sir. kabhi bhi dikkat ho to you are just a call away to resolve the issues. So thank you for organizing such a wonderful webinar. And as you said ki I'm always available, sir. I feel honored when you ask me to join your program. Your program is something, the great value it gives to. It is just not sharing the knowledge. It is actually sharing the experience. So that is in a webinar, actually, it's in the bleeding PV. We all know the bleeding PV in pregnancy can be just a trivial thing, but when it becomes life-threatening, when it becomes challenging, it's despite of all anticipations and predictions, you can land up in something they can't help the upset the patient. So that is something when you're dealing with a pregnant patient, too much of the stress and managing. I don't know why the liver disorders in pregnancy, why the placenta accreta spectrum is so much, you know, every, I can say in every 3 months, I am getting 3 to 4 such referred cases where I feel really, and each case teaches me something new where I miss. So it is very important whenever having a life-threatening hemorrhage, we have to introspect where we went wrong, what we could have done better. And that is something, despite having all the facility, even at AIMS Raipur, the Rotam, the TAG, blood products, easily available, the uterine artery embolization, every facility is available. Despite of that, we are losing the patient. It's not like that we're able to save. So that is what I think this today's webinar is not going to talk about the minor trivial bleeding, and all the challenging cases will be discussed here in the webinar. And I find this type of webinar to be the actually bridging the gap between what the guideline says and what actually is the ground reality. See, we cannot be adhered to the guidelines when you're managing the patient. The promptness and immediate decision makes something which can be done. And I'm damn sure that this webinar is going to resolve all the queries, and the real case scenarios will help us to understand. And this webinar is going to be very fruitful. So as you always of Dr. Vamsi Patel sir, and medical legal issues, बहुत डर लगता है जब patient goes, and then how to face the mob. Despite being in the institute, big institute, it's not like that we can face these challenges. So sir, we will be troubling you whenever we are in the problem. And with this expectation of the great webinar here, thank you so much for inviting me. And I, of course, welcome the speakers, my dear friends, and the chairpersons for this. Thank you so much.
Thank you, Sarita Madam, for sparing time for us. Of course, you are always with us in any of our academic activity. Thank you.
Thank you, ma'am. Our next guest of honor is Dr. Tripti Nagaria, madam. Though she is not there, we will take her blessings when she joins with us. She is a Dean Professor at Pandit J. and M. Medical College, Raipur, State Secretary of Association of Societies of OBGY at Chhattisgarh, past Secretary of ISAR, Chhattisgarh, past Secretary of IMS Raipur branch, past President of Raipur OBGY Society, and she has published 32 papers and contributed chapters into the book, and she's a national editor of Jogi, and she has received Global Signature Award, and she was invited as faculty in more than 150 conferences, and she has organized many international conferences, and she has got a high interest in high-risk pregnancy and infertility. Ma'am, we are looking forward to have your blessings whenever you join. Now, I request Deepika Logane to take over the academic session.
Yeah.
Thank you, Monica ma'am. And I now declare that the inauguration is over. Sir, with your permission, we will be starting with the academic session. But before our chief guest and guest of honor leave, I would request all of you to please support Dr. M.C. Patel sir in all his foxy endeavors, requesting all the Chhattisgarh societies to please support the candidature for President 2026 Foxy. for sir's candidature. Thank you.
Thank you.
Deepika ma'am, over to you.
Yeah. Good evening to everyone. And at the outset, I would like to thank Dr. MC Patel sir and Dr. Monica for giving me this opportunity. And I will be starting with the academic session, that is session 1 of the Happy Learning Masterclass 218th episode. And I begin by introducing and inviting the chairpersons. Our first chairperson is Dr. Archana Chauhan, ma'am. Ma'am is the president of Bhilai Obs and Gynae Society. Ma'am is the district nodal officer for the maternal health and family planning, and also serves as the district nodal officer for POSH, that is prevention of sexual harassment, and for medical legal cases of sexual violence. Ma'am is a national level master trainer for the ARCH program, that is adolescent reproductive and sexual health, as well as for contraception and safe abortion projects. Ma'am, we are honored to have you chair the session, our first session today. I have the privilege of inviting and introducing our next chairperson for the first session, is Dr. Padma Shukla, ma'am. Ma'am is the president of Reva Obs and Gynae Society and is an associate professor in Obs and Gynae. She's also the joint secretary of the Association of Obstetrician and Gynecologists of Madhya Pradesh. Ma'am is the recipient of several prestigious honors, including the Foxy Young Talent Award, Foxy Achievers Award, Dr. D.C. Datta Award, and Dr. D.K. Tank Award. Ma'am has got more than 20 publications in national journals and has authored multiple chapters in Obs and Gynae textbooks. Ma'am, we warmly welcome you to as the chairperson for this session.
Thank you, ma'am.
Our next chairperson is Dr. Geetika Sharma, ma'am. Ma'am is the secretary of Bilaspur Obs and Gynae Society. Ma'am is the director of Umang IVF and Super Speciality Hospital and is a senior consultant obstetrician and gynecologist and infertility specialist. Ma'am has presented number of papers at various national conferences and has been recognized with state level award from Chhattisgarh for her contribution to maternal health services. Ma'am, we are so happy to have you chair our session.
Thank you so much. Thank you so much, ma'am. Thank you. Thank you, Deepika, ma'am.
Can I request our chairpersons to introduce our first speaker for the session, Dr. Sangeeta Sharma, ma'am, who will be speaking on bleeding during the first and second trimester. Can I invite one of our chairpersons to please introduce Dr. Sangeeta Sharma, ma'am?
Yes, may I?
Dr. Geetika, आप कर दीजिए, please.
Yes, ma'am. Dr. Sangeeta Sharma, madam, she is the director of Sharma Hospital and Maternity Home in Bilaspur, and madam is the current president of Foxy Bilaspur Society, and she has presented various publications in reputed journals, and she has won the award in Yuva Foxy North Zone on the paper Thyroid Disorders in Pregnancy. She regularly participates as a speaker in various state, regional, national conferences, and her special areas of interest is operative gynecology. And she has contributed various chapters as an author in textbook and publications, and conducted various awareness programs in many institutes. And approximately 2,000 adolescent girls have been benefited from various health-related and education resistance programs conducted
Thank
by
you,
her.
Geetika. I think this much is enough.
Yes, thank
And
you.
thank you, Dr. Deepika, as well. Let's
Yes.
start the topic because, yeah, my senior, my mentors are there, so
Yes.
it's my
Okay, ma'am.
privilege.
Thank you, ma'am. Ma'am, we welcome.
Let me share.
Yes, ma'am.
Thank you. Can I share?
Yes, ma'am, please.
Just a minute. Is it visible?
It is.
Thank you. Thank you so much, ma'am. So, thank you, Dr. Geetika and Dr. Deepika. for kind introduction. Although I'm feeling very embarrassed in front of my mentors are there. And thank you, Dr. M.C. Patel, sir, the director of this program, and especially Madam Abha and Asha Jain, Madam, for providing me this opportunity. And thank you, Dr. Monica, for providing this opportunity. And chief guest of the day, Professor Dr. Abha Singh, Madam, my sincere gratitude because you are like a role model for all of us here. And guest of honor, Professor Dr. Tripti Nagaria, Madam, although she is not here. And Professor Dr. Sarita Agrawal, ma'am, she is always there as a friend, as a mentor in the time of crisis or in the time of need and help. And by all friends and senior present over here. So the topic allotted to me is bleeding in first and second trimester of pregnancy. So why this topic, although it's very common, but why this topic is of importance? As Madam Abha Singh Madam has elaborated, and Sir has also elaborated the importance of timely timed interference in form of outcome, maternal and fetal outcome, positive outcomes. So it occurs in 20 to 30% of all pregnancies present in first or second trimester of the bleed. So it's a major cause of footfall in the hospital and major cause of maternal anxiety, and even in emergency department in night visits and emergency visits, the patients are of significant number. And it could be benign, that means physiological implantation bleed sometime, or it could be a life-threatening one. So the early diagnosis is of utmost importance. It results in maternal safety and fetal salvation as well. So let's see the trimester-wise overview. The first trimester, it's like a brush up of the knowledge. We all know, but just cover the topic. The first trimester before 12 weeks of pregnancy, the abortion spectrums, it could be threatened abortion, missed abortion, septic abortion, and all. And it could be ectopic pregnancy, which is always an emergency, and it could be molar, implantation bleed, and sometimes cervical region as well. And the second trimester, it is the period between 13 to 28 weeks of pregnancy, and the region be placenta previa, placental abruption, cervical causes, and uterine rupture in neglected and in the rare cases. So how to approach any pregnant women when she comes
spread absorb
problem. So the golden rule in first and second trimester of pregnancy is to see the mother first, to stabilize her first. So the ABC, as we all know, she is in the shock. First, we have to see her blood pressure and all vitals, shock assessment, grading. And first, we have to assess intravenous line, blood grouping, cross matching, typing, and arrangement depends on that her condition. And the focused history, that means how much is the period of amenorrhea, how it happens, the bleeding happens, and the duration, and the per speculum examination, never blind PV. Since time immemorial, our teachers, they are there. They tell us never do the blind per examination. Just do with per speculum examination, we can have a lot of idea about the source of bleeding and the condition. As if the placenta previa is ruled out, we can do the genital PV examination. This is the pictorial presentation of first trimester bleed. Implantation bleed, which is self-limiting and physiological phenomena, although the patient usually comes with panic, of course, and threatened miscarriage. Here, the importance of time treatment is very much, we'll see later on, and the ectopic, which is always an emergency. So let's see the causes in first trimester, as we have already seen in previous slide. The abortions could be threatened abortion, where the treatment is specialized treatment is of utmost importance timely. Inevitable abortion, incomplete, complete, and missed and septic abortion spectrum. It could be ectopic, gestational trophoblastic disease, and physiological one, that is implantation bleed, and sometimes the cervical causes. Although cervical bleeds usually happen in second trimester. So let's see the threatened abortion. Clinically, the patient presents it bleeding, but it's and with mild pain.
bleeding could be moderate or minimal bleeds, and cervix is closed on examination, and in a scan, the pregnancy is viable. So how to manage them? First and foremost is to keep her calm. So reassurance is a must. And the progesterone in selected cases, we will see the guidelines later. And the follow-up ultrasound to know the condition is a must for the stabilization after a week or after 2 days or 3 days or week. It depends on the condition. So the progesterone in threatened abortion, what the guidelines say. Although the progesterone, natural micronized progesterone is there are hardly any side effects, but still we have to know the guidelines. So when the bleed is before 20 weeks of pregnancy, cervix is closed viable, the option of progesterones are there, because we all know the progesterone is endometrial stabilization factor, and its main role is immune modulation at maternal and fetal interface, and it has uterine quiescence action. So what the guidelines say? FOGSI, RCOG, and NICE guidelines. All three consider progesterone with recurrent pregnancy loss. That means if there is previous pregnancy loss, even a single, it works well, they say. So the FOGSI say consider progesterone with recurrent pregnancy loss, RCOG, no routine use, consider in viable pregnancy, of course, with bleeding, with prior miscarriage, and according to NICE guideline, vaginal micronized progesterone if bleeding, and with the previous one or more abortion. So the preferred regime is vaginal micronized 400 BD, and it has to be continued till 14 weeks of pregnancy. So here the key message is use selectively, judiciously, although it depends on person to person, and benefit greatest in women with, it has proved role in with women with prior miscarriage history. So in inevitable and incomplete abortions, she presents with heavy bleeds, cervix is open, products can be seen can be felt in uterus or in the cervix, and it is managed first to stabilize the patient. First, before diagnosis, we have to stabilize the patient, and medical and surgical evacuation depends on her condition and the bleeding amount and duration. And NTD, if she is RH negative, is a must. So here are a few words about the role of NTD immune globulin in threatened miscarriage in RH negative women, of course. So vaginal bleed, whenever an RH negative women present with vaginal bleed with viable pregnancy and closed cervix, we have to consider, because it prevents alloimmunization due to fetal maternal hemorrhage. Of course, it happens in abortion, and it protects this pregnancy as well as the further pregnancy from hemolytic diseases. So what the guidelines recommend, all three FOGSI, RCOG, and NICE guidelines, they say give NTD to all unsensitized RH negative women with bleeding. It is recommended even in early pregnancy bleeds, and they say there's no need to have evidence of sonographic evidence to have pregnancy. Even in chemical pregnancy with bleeds RH negative, we have to consider NTD. So the dose is before 12 weeks, it is 50 to 100, although it's not available in the market. So 300 can be given. And after 12 weeks of pregnancy, 300 microgram is the dose we have to administer before 72 hours of the episode. So the take home is any bleeding with RH negative pregnancy, we have to give NTD. And in the missed abortion, fetal demise without expulsion is missed abortion. And she presents with minimal bleeds and sometimes without any symptoms. In sonography, it is diagnosed as missed abortion. So the management is first and foremost is emotional support. They are usually emotionally rigged people. So we have to give emotional support as a doctor and as a counselor as well. And the management is expectant. Sometimes it expels in itself, and medically or surgically depends on the result of medical. Time and results of the previous one. And the ectopic, which is always an emergency, she presents with period of amenorrhea, history of period of amenorrhea, pain and spotting. On examination, when we do scan, the uterus is of course empty and adnexal mass may or may not be there, and sometimes minimal or the free fluid may be seen in pouch of Douglas. It is managed medically in selected cases, of course, unruptured and stable patient with methotrexate, and surgical intervention usually needed practically, and it's a life-saving emergency procedure. So a few words about the medical management of ectopic pregnancy. It's a focused eligibility criteria. There is no doubt the patient should be hemodynamically stable. The pregnancy should be unruptured. And the beta HCG value, practically the best results come when it is less than 3000 international unit per liter. But they say up to 5000, the results, we may get result with repeat dose as well. And adnexal mass, practically, it should be less than 2.5 to 2 centimeters. It gives the best result, successful in practically in practical, I mean, in the office. So and the guideline says up to 3.5 to 4 centimeter can also be resolved, and without the cardiac activity shouldn't be there. Once the cardiac activity develop at that stage, usually there is failure with the medical therapy, and she should of course be stable condition. Normal CBC, liver function, renal function test should be normal, and with regular and reliable follow-up. With close monitoring, we have to give it. So the treatment is, the preferred one is methotrexate, and the single dose regime is a preferred one, and it's a popular one. So methotrexate, 50 milligram per meter square intramuscular dose at day 1. And we have to monitor beta HCG at day 4 and day 7. And if the decline at day 4 to day 7 is more than 50% or equal to 50% fall, that means the treatment is on the success line. And with inadequate fall and the patient is stable, we can repeat the dose. And the patient is closely monitored and preferred to be in the hospital premises for 3-4 days. So weekly beta HCG, if the trend is on decline, we can check the beta HCG weekly till negative. It usually comes in 2 to 6 weeks of duration. But the point of caution here is, even with a declining trend, there is the chances of possibility of rupture could be there with the despite falling beta HCG. So we have to be very cautious and closely monitoring of the patient. Close monitoring of the patient is a must. So she has to take all due precautions. Of course, alcohol and all, it's okay. And folate should be avoided. Non-steroidal anti-inflammatory, it has blood thinning effect, so it should be avoided. And contraception for 3 months after the successful medical management, because there are chances of recurrent ectopic because of the tubal anatomy is disturbed. So chances of recurrence is always there. So she has to use absolute contraception for 3 and more months, in fact. And about the molar pregnancy, she presents with vaginal bleeds, excessive vomiting because of high beta HCG. Beta HCG values are too high, and uterus is larger than the period of amenorrhea. And it is managed by suction evacuation and the closed beta HCG follow-up to know whether there is the remaining disease, or it is in the rare cases to rule out choriocarcinoma with X-ray and all. So this is the, in brief, the diagnostic algorithm of first trimester bleed. Pregnant women bleeding less than 12 weeks. So we have to assess her hemodynamic for her hemodynamic stability. If she is unstable, first we have to resuscitate the patient and then to rule out the ectopic pregnancy. And if the patient is stable or after stabilization, TVS is preferred and the beta HCG monitoring. So if there is intrauterine viable pregnancy, it's a threatened one. And empty uterus with high beta HCG, it's ectopic, or it could be chemical pregnancy or early pregnancy. And if there is snowstorm pattern, high beta HCG, very high value, then it's a molar pregnancy. Now, the second trimester bleeding causes. The causes could be, usually the causes are placental origin. It could be placenta previa, placental disruption or abruptio placenta. And cervical bleeds, usually polyps, erosion bleeds, it presents in second trimester of pregnancy. And uterine rupture, although it's rare, but it happens in malhandled cases or neglected cases. So it's a pictorial representation of second trimester bleed. Placenta when it's covering, so previa, abruptio placenta, it could be detached, minor detachment, it could be the major one. It may leads to consumptive coagulopathies. And the early contraction with uterine opening, she may presents with bleeding, or the cervical insufficiency, weak dilated cervix or cervical erosions could be there. So the placenta previa, when the patient comes with painless recurrent bleeding episode, painless episode, and on examination, uterus is soft, non-tender, and usually the fetal heart sounds are audible. And avoid digital PV examination in such cases when she comes to us in our OPT. And USG is a must for placental localization. And the cases of placental abruption, she presents with painful vaginal bleed. And on examination, uterus is firm, tender, rigid, and the fetus is usually in distress, or the demise, fetal heart sounds are usually absent in such cases because of abruption. So if she is managed, first we have to stabilize the mother and expedite the delivery as per severity. And the route is usually vaginal, we prefer to. And cervical causes of bleeding are cervical ectropion, cervical, because of high vascularity in pregnancy, may bleed spontaneously, or a history of coitus bleed. It usually happens in cervical erosions. Polyps are there, or infection, cervical cancer in rare cases, and it is diagnosed by perispeculum examination. So this is in brief. Patients, when she presents with bleeding between 13 to 28 weeks of pregnancy. First, we have to stabilize the mother, and then the ultrasound for placental localization. The focus is on placenta mainly. Plainless bleed, it's previa. Painful bleeding, tender uterus, it's abruption. Minimal bleed and the postcoital history, it's usually cervical causes. So we have to avoid the PV examination until the previa is ruled out. So what are the investigation? Here ultrasound is a must. TBS, TAS depends on. And the beta HCG trend, it's not, this is I think not of importance, beta HCG. CBC, blood grouping, coagulation profile in cases of abruption. So the bleeding, it may or may happen with pregnancy loss, but the golden rule is first we have to see the mother's condition. We have to consider the mother's interest first. And first we have to stabilize the patient before diagnosis. It is all again a medical legal importance point. First we have to stabilize, then for other investigation, sonogram and all. So the take home message here is, it's very common, 20 to 30% of pregnancies may present in first and second trimester bleed, and common but unpredictable condition. And the systemic approach, proper approach saves both life usually, and early diagnosis improves the outcome both for mother and fetus. These are simple cases. So just to brush up all this knowledge and to impress upon the mind, uh, although we have
Excuse me, Dr. Sangeeta.
Okay, ma'am. Shall I?
If you will wind up, because we have
Okay.
another talk, similar topic.
Yeah, it's similar to that. Okay, ma'am. Then let me. So thank you so much, ma'am. Thanks, my chairpersons, Archana Chauhan, ma'am, Padma Shukla, ma'am, Geetika Sharma. Hi. So if is there any query or discussion, we can do it later, or as ma'am suggests, Asha ma'am suggests. Thank you, ma'am. Thank you, sir.
Thank you, Sangeeta ma'am. Over to our chairpersons for the concluding remarks, please.
Thank you, Monica ma'am.
I would like to conclude. It was really very great, madam, that you have covered all the aspect of the first and second trimester bleeding. And you very well said that in the first trimester bleeding, we have to stabilize if the patient is unstable, and then dynamically, if patient is unstable, then we should stabilize her first, and we should manage the patient according to the diagnosis of the patient. And in second trimester, yes, the causes you beautifully told that what are the causes and how to manage those cases. This is really important. And as well as I would like to add on that the counseling of the women is really important. And as you said, that mother takes इम्पोर्टेंस सो डेफिनेटली ये तो यही है जैसे मूवीज में होता है कि माँ बच सकता है या बच्चा बच सकता है लाइक दैट तो डेफिनेटली वी विल एज गायनेकोलॉजिस्ट विल से दैट वी कैन सेव द मदर फर्स्ट वी विल सेव द मदर फर्स्ट एंड विल सी अबाउट द बेबी सो थैंक यू सो मच मैम इट वाज एक्सीलेंट वर्क थैंक यू
Thank you,
thank
Padma.
you sir
Thank you.
and
Thank you.
everyone for giving me and Dr. Monica for giving me the opportunity and Asha Jain madam thank you so much.
Yes, thanks, Asha, ma'am.
Thank you, ma'am, for an elaborate second chapter. Now, the second academy, the session we presented with the Tabassum. Ma'am, can you please share your slide that we first introduce our chairpersons for the session? Mayur, can you please share your presentation with the series?
Can you unshare, Dr. Tabasum?
Yes. Stop sharing.
Monica, you are muted. Monica?
Sorry. Yeah. Now, can you hear me, please?
Yes.
Yes.
Our chairpersons for the second session is Dr. Paulami, Dr. Rashmi Sharma, ma'am, Dr. Jyoti Jaiswal, ma'am. Dr. Paulami is an IVF consultant at Matrika IVF Services at Raipur. The next slide, please. Yeah. She's an ex-consultant at Nova IVF Center at Raipur and Diva Fertility at Nagpur. She also holds a fellowship in infertility and reproductive medicine from Gunashila IVF and Genomics Center. We welcome you, Dr. Paulami. Our next chairperson. The next slide, please. Dr. Rashmi Sharma, madam, is a senior consultant at Apollo Hospital at Bilaspur, and she has special interest in high-risk pregnancy, endoscopic surgeries, and cosmetic gynecologist. She has been the past clinical secretary, the secretary, and the president of the Bilaspur OBGYN Society currently. We welcome you, ma'am.
Pen or prescription.
Yeah.
Your paper.
Our next chairperson, Dr. Jyoti Jaiswal, madam, is a professor and the head of the department at Pandit Jawaharlal Medical College at Raipur. Madam has been the national treasurer at IMS, the chairperson of the ISAR Chhattisgarh chapter, treasurer of Chhattisgarh IAG, secretary general of Raipur ISOPA, and secretary general of Chausi Chhattisgarh chapter.
Thank
We
you,
welcome
Dr. Monica.
you, ma'am.
My all mentors are there. Thank you so much.
Yes. Yeah, and we request our chairpersons to please introduce our speaker for today.
Should I introduce?
Yes, ma'am, please.
Hello.
Yes, ma'am. Rashmi, ma'am, you can.
Yeah, Dr. Tabassum Dhalla is Vice President of Raipur Menopause Society. She's Joint Secretary of SOFC Raipur chapter. She's President. She has been President of Raipur Ops and Gynae Society 22 to 24. She's also Vice President of IMA Raipur 2023. Then she's Director at Zvezda Hospital Raipur. I welcome you, ma'am, for your talk on third trimester bleeding.
Thank you, Rashmi ma'am, for those kind words. Let me share my screen first. Share over.
Till Dr. Tabassum is sharing the screen, I must thank Dr. MC Patel and all the stalwarts of Chhattisgarh are, we can see here, they are here. Sir has chosen everybody and put it here, so we all are together. Yes, Dr. Tabassum, the platform is yours.
Good evening, everyone. At the outset, I would like to thank MC Patel, sir, for inviting me as a speaker. It's my proud privilege to present today, especially in front of my mentors, Dr. Abha Singh ma'am and Tripti Nagari ma'am. Unfortunately, she is not there. Thank you, Sarita ma'am, too, for being here. And thank you, chairpersons, Dr. Jyoti Jaiswal madam, Rashmi madam, and my dear Paulami. So, the previous speaker has spoken a lot about the bleedings. So second trimester bleeding and third trimester bleeding has overlap, as we know. So we are going to have some overlaps here, but let's brush up again. Let's go back to our basics and learn again. We'll cover this third trimester vaginal bleeding in a very short way. So why is this topic important? Why this topic matters? One of the most anxiety-provoking obstetric emergencies is the third trimester vaginal bleeding, as you all know. It has got high maternal and perinatal mortality and morbidity. Outcome, it depends on early recognition and correct decisions at correct time. Protocols plus, very important, clinical judgment. So it's not just protocols, but a clinical judgment is very important, and this will give the best results. So definition is any bleeding per vaginum after 28 weeks of gestation. It is also called as antepartum hemorrhage, can be placental, non-placental, or unexplained. What are the causes of this APH thing which is happening? Very important is placenta previa. Second is placental abruptio, vasa previa. Then there can be some local causes like cervical polyps, cervical erosions. And when everything is excluded, when we call it as unexplained APH. The golden rules, as Dr. Sangeeta has also mentioned, these golden rules are non-negotiable. Mother first, fetus second. No digital PV examination until placenta previa is excluded. But in a very less resource setting, if you've got no access to ultrasound, then very gentle PV can be done with caution, I would say again. Resuscitation and diagnosis run simultaneously. It's not like we resuscitate and then we go for a cesarean, or we resuscitate and then we do something else, we induce. No, both go simultaneously here. And early senior involvement saves lives. So this is for all our PG students and juniors. They should know that कभी-कभी बहुत होशियारी problematic हो सकती है ऐसे cases में. So it's always better to have people around. Even I would tell our fellow colleagues that even if you are there alone in a single specialty hospital, call someone for help. There is no harm in calling for help. What is the initial assessment? Assess ABC, that means the stability of the patient, and vitals. Always put 2 wide bore IV cannulas. Blood grouping, cross matching, CBC and coagulation profile is must. Then immediately one of the staff will assess the fetal heart rate by either CTG or a Doppler, or with a stethoscope if it is not possible. So let's come with some cases here. This is a case 1 where a 32 years old, gravida 3, para 1, living 1, 34 weeks of gestation, sudden painless vaginal bleeding, previous LSCS. I think the words only tells what's the diagnosis. So the provisional diagnosis here is of course placenta previa. Now, in this case, the vitals are stable. Abdomen is soft, it is non-tender. FHS, fetal heart sound is reassuring. Ultrasound shows a type 3 placenta previa. Mother and fetus are stable and gestational age is less than 36 weeks. So what will we do? Are we going to operate immediately? If the mother and fetus are stable and we are able to stabilize them, then definitely we are going to go for an expectant management here, right? So now in placenta previa, we should also confirm placental location. Preferable is transvaginal ultrasound. When we were studying, they used to tell us that you should never do a transvaginal ultrasound and everything, but no, transvaginal ultrasound is always preferred even by RCOG guidelines. Assess bleeding severity and gestation. Stable, if the patient is stable and the patient is less than 36 weeks, go for expected management. Recurrent bleeding more than 36 weeks, plant cesarean section. Blood and NICU readiness is mandatory. We cannot compromise on NICU readiness. Now going to the second case, which is a 28-year-old gravida to para 1, 36 weeks gestation, severe abdominal pain plus vaginal bleeding. She also has a history of PIH. What worries you most? Clear cut, this is a case of abruptio placenta. So what worries you most? It is severe bleeding and the patient may have PPH later on, right? So patient has pallor, she's got tachycardia, abdomen is tender, uterus is rigid, fetal heart shows late decelerations. Ultrasound is inconclusive because in abruptio, ultrasound mostly cannot diagnose abruptio very well. So we cannot rely on ultrasound in case of abruptio placentae. So this is a placental abruption. Diagnosis is clinical always. Mostly do not wait for ultrasound. And this also carries high risk for DIC and PPH. So we have to act fast. And what is the practical algorithm for placental abruptio? Immediate resuscitation. Send coagulation profile. If the fetus is alive and there is distress, expedite delivery. Immediately we should think of delivery, however the delivery is possible. If there is a fetal death, then vaginal delivery is preferred. Cesarean section should be done for obstetric indications only. Coming to our next, that means the third case, which it is an emergency scenario. This is a primary gravida at 38 weeks, sudden bleeding after rupture of membranes. So maternal vitals are stable, sudden fetal bradycardia. What is the diagnosis? Vasa previa. It is an emergency, so suspect fetal hemorrhage, avoid PV examination, immediate emergency cesarean section, neonatal resuscitation team should be ready always. Now coming to the unexplained ABH. Diagnosis is by exclusion. It is also associated with preterm labor, IUGR, stillbirths, and they require very close maternal and fetal surveillance because things can take turn anytime, even in these kind of cases. When to deliver immediately? In any APH, when do we deliver immediately? If the patient is hemodynamically unstable, if there is uncontrolled bleeding, if there is fetal distress, and if the gestation is term and APH is happening. Now there are differences in different kind of guidelines, like FOXI says something, RCOG says something, but what is the philosophy behind it? FOXI says hospital-based treatment, safety-oriented. RCOG says individualized, resource stratified. But core principle of both FOXI and RCOG is same. Core principle remains the same, that is baby and mother first, always. So these are the differences. Hospitalization in previa, routine inpatient Foxy says routine inpatient. RCOG says selective outpatient. Ultrasound, transabdominal or transvaginal, depending on the availability. RCOG strongly prefers TVS. Timing for cesarean section, 36 to 37 weeks. Same by RCOG. CTG is recommended, but RCOG says it is mandatory if the fetus is alive. Abruptio, cesarean section as obstetrically indicated, and same by RCOG if it is indicated. What are the common pitfalls? Waiting for ultrasound in abruptio? No. If you clinically suspect abruptio, go ahead. Unnecessary PV examination, unnecessary word is important, unnecessary PV examination should always be avoided. Delay in blood product use, you should immediately start blood. You should not wait for things to turn around. Poor communication with anesthesia team and NICU. So it's very important to be in a very good connection with NICU and anesthesia team. So what are the practical consultant pearls? Bleeding severity guides urgency. If the patient is bleeding profusely, forget about protocols, start acting. Abruptio is a clinical diagnosis. Investigation should never delay delivery. Early team communication saves life. So communication. It's very important that we all work coordinately. What lab evaluation we are going to do? Complete blood count with platelets, A-type and cross-matching, prothrombin time, APTT, INR to evaluate coagulation factors and fibrinogen, blood urea nitrogen, creatinine, electrolytes. Very important for very low resource setting is a wall clot is useful test to assess coagulopathy with acute bleeding. What do we do in this? We just in the red cap thing, we have to put the blood and keep it aside and see for coagulation. How much time it is taking it. If it is taking more than 6 minutes, that means there is a problem. And if the patient is RH negative, we should always go for Claver Batcase test and find how much is the feto-maternal hemorrhage. A standard RH immunoglobulin dose of 300 micrograms should be administered to patients with bleeding who are RH negative, unless KB stain test suggests there is additional hemorrhage. If there is additional hemorrhage, we have to give a little more dose. Coming to SFM and ACOG recommendations. It recommends delivery at 36 to 37 weeks and 7 days for stable women with placenta previa without bleeding or other obstetric complications. Does not recommend routine cervical length screening for women with placenta previa in the late preterm period due to a lack of data on an appropriate management strategy. Recommends delivery between 34 and 37 weeks of gestation for stable women with placenta accreta. Recommends delivery between 34 to 37 weeks of gestation for stable women with vasa previa. It also recommends that in women with active hemorrhage in late preterm period, delivery should not be delayed for the purpose of administering antenatal corticosteroids. It also recommends that fetal lung maturity testing should not be used to guide management in late preterm period when there is an indication for delivery, when the indication of delivery is present. It also recommends that antenatal corticosteroids should be administered to women who are eligible and are managed expectantly if delivery is likely within 7 days. The gestational age is between 34 and 36 weeks 7 days, and if antenatal corticosteroid has not previously been administered. So these are some very important recommendations. It also recommends that antenatal corticosteroids should be administered to women who are eligible and are managed expectantly if delivery is within 7 days. This we already read. So coming to the surgical principles of placenta previa. Abdominal incision, phalansteal incision if the patient is stable and expected easy delivery. Vertical midline if suspected placenta accreta spectrum. Anticipated hysterectomy is there, or if the patient is obese and previous multiple cesarean sections. Uterine incision, most critical step. Principle is avoid cutting through placenta. Placenta anterior low line. High transverse incision should be given, or you can also give a J or inverted T-shaped incision. Placenta is posterior, standard lower segment incision is fine. If placenta is cut, in case you have to cut the placenta, and you have to cut it sometimes, then the delivery of the baby should be very rapid. Clamp the cord immediately, prepare for any kind of torrential bleeding. Placental delivery, never forcibly remove placenta if it is adherent, accreta is suspected. If accreta suspected, intra-op, close uterus with placenta in situ, proceed for cesarean hysterectomy. Coming to surgical principles of vasa previa, surgical entry, do not rupture membranes blindly is very important. Open abdomen and uterus carefully. Incise uterus slowly. Identify membranes before rupture. Rupture membranes away from visible vessels. Accidental vessel tear, acute fetal hemorrhage will happen. Delivery techniques, immediate clot clamping should be there, rapid neonatal handover should be there, and anticipate neonatal anemia or acidosis also. Placental examination is mandatory in this medical legal era. We should always examine the placenta and also take a picture and keep it documented. Velimitous cord insertion is there, ruptured fetal vessels are there, important for documentation, medical legal safety, and future counseling. So what are the key take-home messages? Follow algorithms, trust clinical judgment. FOXI and RCOG agree on core principles. Stabilize the patient first, deliver when indicated. Timely action saves 2 lives. Thank you very much.
Thank you, Dr. Tabassum. It was really a wonderful and to the point talk. Absolutely related to the points which are very important for the discussion. For everybody's convenience, I will reiterate few points which are important from your talk. That first you said that protocol plus clinical judgment. If our clinical judgment is not applied, we cannot follow the proper protocol. So it is really a must thing which you have highlighted, that protocol plus clinical judgment. Second, very early involvement, because every minute counts. टाइम ही नहीं है वेस्ट करने के लिए. Each minute counts. You have only one golden hour in your hand. In that, you have to do everything. So appropriate involvement, early call for help, and appropriate help also. The third thing which you said about the TVS for the assessment wherever is possible, and as you suggested two guidelines, FOXI as well as ACOG. FOXI guidelines are more Indian continent friendly. Because like they said that TAS or TVS, anything can be done, because we do not have each and every place the TVS probes. So whatever is available can help us. One very important point you highlighted about the bedside clotting test. In a low resource setting, this is such a boon that which can guide that how much amount of the other thing, blood products, and the referral and all protocols can be followed with the help of this bedside clotting test. One important thing that in the current scenario where placenta previa is being commoner and commoner day by day because of the previous sections, and many a times when placenta previa is there in the previous any kind of operation, and which is most common is the previous LSCS, it is associated with the PAS. So two important thing you said about the vertical incision is better in the PAS. And second, one point I wish to add from my side, then if placenta previa is associated with PAS and you are thinking that the hysterectomy will be needed and you need to remove the uterus, don't waste your time for any other thing, for prior internal iliac artery ligation or anything. Just go ahead for the fast hysterectomy without wasting any time. If you need to require the removal of the baby in that situation, when you are going to do the obstetric hysterectomy, even our vertical transfundal incision is also appropriate for those conditions. So thank you very much for your talk. And if the organizers can allow, 1 or 2 questions can be taken. Otherwise, we can go ahead.
Thank you, Madam. It was a wonderful session, and
Yes, Dr. Palu.
Yeah, it was a wonderful session, ma'am. And as Dr. Jyoti ma'am said, that timely intervention is the much required thing. And apart from that, if we counsel the patients in the antenatal period itself for the consequences which can happen, then timely preparedness and a MRI to look for the like to rule out the morbidly adherent placenta at the antenatal period only will be more helpful to guide the patients and for the preparedness for us as well as the patient party during the if any untoward event happens during the management or during the stay in the hospital. So counseling is very important, especially in previous, as madam said, that lot of previous LSAS cases we are getting. So in all such cases, if the placenta is anterior, a small counseling session during the antenatal checkup is very much important.
Yes, yes, very good point you have brought about.
Thank you, Chairperson, and thank you, Dr. Tabassum, for an
Thing I want to
elaborate
add
talk.
because
Yes, ma'am.
moreover here our fertility practice are increasing. This placenta accreta syndrome is coming in touch, like in clinical practice, are getting more cases because we are more doing the FET. Freezing cycle, and in that case in my practical clinical practice we are getting so many cases, and the whole 9 months they are coming with spotting bleeding, and if you do ultrasound there is nothing, everything is good, and when we operate for we are going for cesarean section, we are getting like very commonly adherent placenta. So this thing we have to be very careful. We have to take the history. Is there any reproductive association or any procedure has done? And if there is freezing cycle transfer, then we have to keep in our brain that there may be adherent placenta.
And especially if they have a previous myomectomy or a septal
That
resection.
scar, too, it's
Scar.
100%. If any scar is there in history, we have to keep. But in my practical experience, I'm getting in cesarean section also, everything is good. But usually they're getting preterm deliveries. And when you are doing like 34, 35, 36 weeks, there is high chance of placenta accreta syndromes. We're getting it. So we have to keep in mind and prepare the patient, counsel the patient properly.
Thank you, Tabassum. Thank you. You know, you accepted my invitation in 2 days. I'm extremely grateful.
Thank you.
Extremely grateful.
I'm grateful that you gave me the opportunity and sir gave me the opportunity. Thank you.
Thank you, Asha
Thank you,
Didi
ma'am.
and MC Patel sir and the whole team.
Thank you, ma'am. We now move forward to the next session. Can we have the CV slides, please? Our third session will be taken by Dr. MC Patel, sir, on the legal issues in obstetric hemorrhage. And our chairpersons for today, Dr. Mahesh Prasad, sir. Dr. is practicing at Nehru Shatabdi Chikitsalaya at Giant, and he is currently the secretary of the Singrauli OBGY Society. Can I have the next slide, please? Dr. T.K. Sahu, sir, is professor and head of the Department of the Government Medical College at Raigad, currently working as a professor. He has been in teaching since last 2014, and he's a master trainer of emergency obstetrics, PSC, SBA training, and the PPIOCD program. He's the founder and president of the Rajgarh OBGY Society. We welcome you, sir. And our third chairperson, Dr. Rekha ma'am. She is currently attached to Apollo Spectra Hospital and owner of the Tanisha Hospital at Riva. Madam has received the Cervical Cancer Awareness Award in 2022, the Dr. Durusha Trophy Award in 23, the Mailan Smriti Award in 23, and Dr. Gangacharan and Chitar Award in 2024. We welcome our chairpersons and we request them to introduce our speaker, Dr. MC Patel, sir.
Good evening, everyone. Thank you for giving me the opportunity. Dr. MC Patel, sir, is a great consultant, obstetrician, gynecologist, a learned trainer, and a medico-legal counselor. Sir is a candidate for Foxy Presidential Election 2026. Sir, my best wishes for your upcoming elections.
Thank you.
Sir, welcome for your talk on medico-legal issues on obstetric hemorrhage.
Okay,
Sir is
you.
a medico-legal... Yes, sir?
Yes.
Sir,
Continue.
medico-legal trainer and supporter for every members. Sir is a Vice President Foxy 2018. Sir, Organizing Secretary AICOG 2017. Sir was Organizing Chairperson MMCon VPCon 2018. Sir, PNDT NIMC Government of India 2015. Sir has given many services in medical camps in Northeast states under Dhanvantri Seva Yatra under NMO and Seva Bharati organized since 23 years. Sir has given services in medical camps in Jammu and Kashmir under Dhanvantri Seva Yatra under NMO and Seva Bharati organized since 6 years. Sir has been President Lions Club Ghatlodiya 1917 to 1980. 1980. Sir has been President AOGS 2010 to 2011. Sir has been President IMA Ahmedabad 2007 to 2008. Sir has been National President NMO 2016 to 2018. Sir has been Organizing Chairperson Vivekanand NMO Conference 2013. Sir, now you are better for your talk.
Okay. So thank you, madam, for kind word. Let me share my screen. So is it seen?
Yes, sir.
Is it seen full screen?
No, sir. Yeah.
So greeting from Statue of Unity, tallest statue of world, and we all are proud of that statue. My slide is moving.
Not
Hello.
yet.
No?
Not yet.
No, it's not moving, sir.
Not
No,
moving, sir.
yes, there is some problem. So I will have to go this way only. So greeting from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all my team, Dr. Monica Umardan, convener, Dr. Monica Gupta, Dr. Deepika Logani, Dr. Satabdi, Dr. Kamlapur, and Dr. Nivedita, coordinator of this series. And I also thank you all because during my last election, you had been to with me just like a rock. Though I lost, but I believe in this. This is very rightly written by Shraddha Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में करते हुए के पथ पर जो भी मिला ये भी सही.
Right, sir.
वो भी सही. So loss is not the end, but new beginning and journey to Sub Foxy continued with renewed patience. Because wherever you are, I will be there, promise to reach the unreached, and seeking your blessing for the same post President Foxy this year, election year 2026. Usually I start any of my talk with this question: is it worth discussing legal issues in obstetric hemorrhage? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. Because in our day-to-day practice, we take utmost care of any of our patients in any given situation, but accident may happen. And once one accident happens, it becomes a potential area as far as litigation is concerned. And we have to save mother, we have to save baby, and at the same time, we have to save our own cap. This is our obstetric practice. And we always worry about safety, but whose? Patients or doctors too? So legal safety is priority in medical practice nowadays. Let us see, this is real happened case in state of Gujarat only, and I was legal counsel in this particular case. It was unbooked patient, primary 34 weeks PIH. Actually, this patient was taken care by another gynecologist in another town, but in Gujarat, it is a customary tradition that first delivery should be at maternal place. So she had been to her maternal place and they came to this gynecologist very first time. So 34 weeks pregnancy, PIH. She was advised necessary investigation and necessary treatment. But unlucky that patient and gynecologist, very next day, she developed abruptio placentae and intrauterine fetal death. Cesarean section was advised. Relative opted option to go to another town for second opinion, went to surgeon in nearby town, and surgeon went with cesarean section, but again unlucky patient and unlucky that surgeon too. She developed atonic PPH, and in spite of all their efforts to control bleeding, ultimately hysterectomy was done. Case was filed, notice was served. Allegation to first gynecologist was not properly managed to prevent abruptio placentae, and to surgeon not tried to prevent PPH, and atonic PPH was not managed properly. So these were the allegations. So in this particular case, as far as first gynecologist was concerned, so my simple argument before Honorable Court was, it was very first visit with this gynecologist, and he diagnosed she was 34 weeks pregnancy, PIH, and he advised all the necessary investigation and necessary treatment. So what best one can do in that very given situation, he has done. So he was out of a problem in this particular case. As far as surgeon part is concerned, not tried to prevent PPH, and atonic PPH was not managed properly. As such, in this particular case, when PPH happened, surgeon was doing cesarean section and gynecologist was assisting. So they went with oxytocin, ergometrin, carboprost, then 2 units of PCV, stepwise devascularization, compressive suture. So they tried their level best to control bleeding, but in spite of all the measures, they couldn't control, and ultimately hysterectomy was the only answer, and hysterectomy was done. So my argument for this was, we have not removed uterus. We have sacrificed uterus to save life of patient. And in spite of all the efforts put, when patient was not getting this bleeding control, then hysterectomy was the only way to save life of patient. Let us see one more case. In this case, again, it was case of cesarean section, atonic PPH after cesarean delivery, uterotonics given. In spite of applying sutures, bleeding PV was 3+. So informed consent was taken, and subtotal hysterectomy was performed. So blood and its components transfused to correct hypovolemic shock. So in this particular case was filed against a doctor. Argument on part of doctor was, it was life-saving emergency. When PPH occurs, and in spite of all our efforts, if we cannot control, then either we have to go for subtotal or total hysterectomy, whichever the case. So in this particular case, they came up with standard textbook of Shaw and Williams for references. And in both the textbook, it is very specifically mentioned, particularly in Williams, it is mentioned that in this type of situation, one has to take chance to save life of patient. And inference held by the court with this argument and textbook references that postpartum hemorrhage is well-known complication. It is dreaded and leading cause of maternal morbidity and mortality worldwide, even in best centers. The process of childbirth can take a lethal turn. Only a qualified obstetrician can understand uterine atony after childbirth as the most common cause. In this particular case, uterine atony was the reason. It can lead to rapid and severe hemorrhage, shock, DIC, multiple organ failure, and ultimately death. And it was observation put in few studies. The most common indication of emergency obstetric hysterectomy was uterine atony, almost in 25% of the cases, followed by morbidity adherent placenta in 21%, and uterine rupture in 17%. So this reflects that, a situation in most developing country where atony accounts for majority of cases of emergency obstetric hysterectomy, but also shows a rising trend. So in this particular case, court has one further inference that if all attempts at arresting bleeding have failed. Subtotal or total hysterectomy is attempted as a last resort and it is life-saving measures. The decision to perform hysterectomy, although devastating for patients, should not be delayed in case of hemodynamically unstable patient if need is there. So this case was dismissed in favor of doctor and doctor was saved in this particular case. So which are the areas for litigation in this type of situation? Which are the most common allegation usually we have to face? Delayed in diagnosis, investigation and treatment, misdiagnosis, investigation and treatment, wrong diagnosis, unnecessary investigation, no consent taken, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all we have to transfer patient to higher center, and if it's delayed, then it is also one cause as far as litigation is concerned. So complications, morbidity, maternal and or fetal, and mortality, maternal and or fetal could be the reason. Overcharging nowadays, this is also one of the causes that there is overcharging, and particularly claim is like this tremendous expense against unexpected reason. And ask for medical records and not provided is also one more reason for allegation. Failure of patient to keep up scheduled follow-up is also one condition. So which are the areas as far as litigation part is concerned, not anticipated or not prepared to manage? Say for example, if it is a case of placenta previa, naturally one should anticipate that she may have PPS, she may require blood transfusion, she may require obstetric hysterectomy, and one has not anticipated, one is not prepared to manage this condition, then it becomes difficult in court of law to face in litigation in this type of situation. So usually whenever we are facing this situation, very important question is asked, was it preventable? So we cannot say no usually. So if it is yes, then what did you do to prevent it? Say for example, it was placenta previa and we know that PPH may occur, but if we have taken proper measures to prevent and to manage accordingly, then we are out of problem. So what did you do to prevent it? And in spite of all your care and caution, you couldn't prevent. Many a time it is not all the way that you can prevent all the complications. So if you couldn't prevent, then did you diagnose that complication in time is very important question. And one very important question, did you manage way in which any prudent doctor would have managed in that very given situation? So these are the bunch of questions you have to face in court of law. One more area just I mentioned, delayed in diagnosis, and all the same question you will have to face. Was it preventable? Yes. What did you do to prevent it? Why you couldn't prevent it? Did you diagnose in time? No. Did you manage way in which any prudent doctor would have managed? So you have to face all this. Recurrence. If it is a bout of bleeding PV during pregnancy, and if you have managed, and it is likely in few of the condition, she may have recurrence also. So in this type of situation, common allegation is no proper care taken to avoid recurrence, and same bunch of questions will be asked in this type of situation. And this is our observation during our medical legal practice. 80% medical legal cases against gynecologists are obstetric related, and 80% of these cases are related to cesarean section complication, and 80% complications are related to hemorrhage. So if one wants to be 80% free of litigation, take care of bleeding and cross-match blood and be ready to transfuse blood well in time. Let us see this case, real happened case in city of Ahmedabad only, and how this case went. It was case of cesarean section, and during cesarean section it was bilateral uterine artery tear. As such, before 4 days, she was advised to get admitted and for elective cesarean section with preparation of blood. But she absconded from the hospital, and after 4 days, in middle of the night, she came in an emergency, and obstetrician had to rush for cesarean section only and unlucky that obstetrician and patient, there was bilateral uterine artery tear, patient was RH negative, blood was not ready, cross match was not done, and during shifting patient to Municipal Medical College Hospital, patient expired on the way. Notice was served, case was filed, and allegation was not anticipated complication, procedure, or intensive care, and she was not prepared to deal with the situation accordingly. So in this particular case, post-mortem examination was done, and there was a comment on part of person who had done post-mortem examination, intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready. This was inference held by the court, and medical records not to be believed. So note of gynecologist and note of anesthesiologist were contradictory. In note of gynecology, she had written vitals were within normal limit. And at the same time, in note of anesthesiologist, he had mentioned that vitals were compromised. So there was contradiction between note of gynecologist and anesthesiologist. So in this particular case, records were not taken into consideration, and compensation of rupees 2.35 lakhs was awarded in favor of a patient. Let us see one more case. In this particular case, again, it was Rh negative group patient. Indirect cum test was done. NTD was given at 32 weeks of pregnancy. In this case also, there was atonic PPH during the cesarean section, and ultimately subtotal hysterectomy was done. And during course of treatment at tertiary care center, patient expired. So during this case, it was decided in National Commission. National Commission didn't hold doctor negligence in managing the patient, but he had a comment also, no negligence in management, but blood should have been arranged or patient should have been referred to higher center well in time. So common reason for litigation in this type of situation is not cross-matching blood during high-risk pregnancy cases, just like Rh negative or so. So what is carry home message in this type of situation? Would you advocate prior cross-matching in each and every cases? Many of us has a habit, including myself, to send sample in nearby blood bank and keep 2 units of blood ready irrespective of mode of delivery, whether normal, instrumental, or operative. If at all it is required, then we can demand. If not required, fine. But if it is ready in blood bank, it shows your consent that you had taken utmost care of your patient. And particularly when patient is Rh negative, it is compulsory, I would say, that there should be at least 2 units ready nearby in a blood bank. And consent for blood transfusion is also very much required, and proper record keeping, just I mentioned, is very much required. So obstetric hemorrhages are like 9/11, and it is very late sometimes when we diagnose the thing, and one cannot be smarter every time to get rid of the problem. And after the ship is sunk, everybody knows how it could have been saved. So as far as this PPH part is concerned, or any bleeding during pregnancy part is concerned, they are potential threat as far as litigation is concerned. And treating serious patient could be suicide. And whenever something goes wrong, we are bombarded with so many questions. And usually people ask, why this happened? Where were you? How you couldn't prevent it? Who is responsible for that? So in this type of situation, what to do and how to prevent? So court and law expect from us practice foreseeability or anticipation, good communication and proper consent and documentation, and you will be simply sail through. So as far as anticipation is concerned, just I mentioned prior also that if it is a case of placenta previa, naturally one should anticipate that she may have PPS, she may require blood transfusion, and she may require hysterectomy also. When one should be vigilant or anticipate PPH? It is a very important question asked if at all you are facing any case in a court of law as far as PPH management and ultimately hysterectomy has done, or some mortality has happened. So in atonic PPH, we should be very careful when we are dealing with this type of situation, multiple pregnancy. Naturally, one should anticipate that she may go in atonic PPH. Grand multiparity, large baby, anemia, polyhydramnios, prolonged labor, placenta previa, placental abruption, retained placenta, remnants of placental tissue, retained amniotic membrane, blood clots, mismatched third stage of labor, and full bladder. So these are the conditions one should anticipate that she may uh, go in atonic PPH, and we should be really available to deal with the situation. Would you like to involve other colleague in this type of situation whenever you are dealing with a case of PPH or severe bleeding during pregnancy? Would you like to treat alone? It's a very important question. So no, I am only consultant approach. Always involve professional colleague in this type of situation because it shares your responsibility. And when you are dealing with this case at your hospital, naturally you are in uh, a scared condition. And one person comes from outside, he is with fresh mind, and he will be much more helpful to you in this situation. And one more thing, it shows your concern to save life of patient. So it is always better to involve professional colleague in this type of situation because balanced teamwork is always beneficial, not to the patient only, but to us also. But in all this situation, proper counseling is very much must. So would you give guarantee in this type of situation whenever patient is bleeding or if it is a case of PPH? No, because no rosy picture about result. You can give guarantee of your best of your efforts, but you cannot give guarantee of ultimate outcome. So no rosy picture, no tall claim, because when you claim to be master, in eye of law, you are supposed to be master. And in our day-to-day practice, we consider our result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture. And naturally, proper record keeping is very much must. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. This is also very important part. Important bills is also part of your record. Say for example, purchase of oxygen cylinder, defibrillator, ventilator, emergency instrument like ambu bag, emergency drugs, and very important part is not only purchase of oxygen cylinder, but refilling of oxygen cylinder bill is also part of your record. Because in this particular case, allegation was when patient suffered heart attack, oxygen cylinder were empty in the hospital, and we were saved in this particular case only due to we could produce bill of refilling of oxygen cylinder just one day prior of this accident happened. So this is very important part in this type of situation. Transfer of patient. Many times we have to transfer patient when patient is bleeding or it is a case of PPS. So in this situation, it should be in time transfer. But naturally after stabilizing patient, we have not to transfer patient when patient is unstable hemodynamically. At proper hospital. Why at proper hospital? Because many a time we consider that she may require blood transfusion, and when patient reaches there, blood is not available in that very hospital, operation theater is not available. So always confirm about availability of bed, ventilator, OT, blood, wherever you are referring the patient, and escort in the same ambulance. Handing over patient is very important with date and time, and transfer document, you have to give all the transfer document to the patient. And use of pneumatic anti-shock garment is also equally important. It shows your consent in court of law. And as far as transfer document is concerned, I do not want to go into details, but you have to give all the transfer records of treatment given to your patient. There is a checklist, but you have not to go into detail. It is available on Foxy website under this title Foxy Uniform Consent. 30 different consent are available on Foxy website. We three medical legal expert, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent, and in those consent, how to transfer patient and which kind of document we have to prepare at the time of transfer is also given in that very situation. And this is checklist of that very document. And preserve transfer note of patient transfer to higher center. So whichever document you give to them, you have to preserve one copy with you. So there is always a way to, so to conclude my talk with Kerry Holmes, antenatal and labor ward protocols we have to strictly observe and follow. It saves in court of law whenever you are facing any litigation. Adequate supervision and monitoring, communication, counseling and proper consent, documentation and proper record keeping, foreseeability and anticipation, in-time transfer, multiple approach, multi-speciality approach, and medical audit of your own case. So not to end up into same type of situation again, and indemnity in era of this CPA. So medicine is a science of uncertainty and art of probability. And problem with world is still is there that intelligent people are full of doubts while stupid ones are full of confidence. So remain alert every time. And this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient. Take proper care at the time of dealing with any bleeding during pregnancy or PPH. Pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any odd given situation. So all the best. Have a litigation-free medical practice with regards. And before I end, please endorse my candidature for post of President Foxy election year 2026. Salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any query, any questions, if time and chairpersons permit. Thank you. Thank you very much.
Thank you so much, sir. Very nice presentation. Sir, everything you told very nicely. I want to add one more thing in documentation.
Yes.
Sir, that is video recording while we take counseling and while we do counseling and take written consent.
So video
Sir,
counseling and video consent is equally acceptable in court of law, but I would say it is double-edged sword. Why?
yeah.
Because if you miss any important point to discuss, then that point can be taken into consideration. So even if you go with video counseling, printed copy should be there on your table.
Yeah.
And you will quickly go through that you have not missed any important point to discuss at the time of counseling and at the time of taking consent.
Sir, an important incident happened in our medical college in Riva.
Yes. Yes.
Sir, in that case, Operation Theatre, there was a huge fire during an LSCS, and it was a case of placenta previa, and baby was IUD. And it was the case of placenta previa, baby was IUD. At the time of fire, the baby was out, and operation was going on. And second layer was, during the second layer, it was the fire. And everyone was out of the OT, and one OT assistant was able to take out the patient out, and everyone doctor was also out, but जो IUD baby था वो अंदर रह गया OT के अंदर, and the baby was burned, and whole the media and सारा मॉब कमिश्नर सुपरिंटेंडेंट बॉस कि जिंदा बेबी को जला के मार दिया मेडिकल कॉलेज वालों ने. तो इट वाज सर दैट केस, एंड गुड थिंग वाज कि एक जो जूनियर रेजिडेंट था उसने काउंसलिंग के समय और कंसेंट के समय वीडियो बना लिया था. So that video was very important and it was presented to collector and commissioner all and उसमें टाइम और रिकॉर्डिंग सब था डेट कि
It
बिफोर
was old IUD.
it was old IUD.
Yes. But in the same case, if you had mentioned in written consent that this is already dead inside, explain to us which are the consequences of IUD and during cesarean section which are the probable complication also, then it is equally good even if you have not video counseling. But if it is video counseling, fine, it is always added tool in our favor.
हाँ ये सूती था लेकिन आपको ठीक कोई बात नहीं दूसरा नया ले लेंगे सूती का
Rashmi ma'am, your mic is on. Rashmi Sharma ma'am, your mic is on.
Thank you, sir.
So, any other question, or we have to switch over to panel discussion?
Sir, can I just ask one question to you, if permitted?
Oh, yes.
Sir, I had discussed in my college council meeting that the long consent forms and informed consent and risk explanation are sometimes in the busy scenario it becomes a problem, and Foxy has come up with a beautiful consent form. So can we get it printed out for the patients, and if something extra is there, so we can add on 1 or 2 line whatever is not mentioned there, and rest we can go ahead. So 1 or 2 faculty pointed out that your these printed consent forms are not valid in the court, madam. So I said they are made by the experts who are knowing legal points well, and they are expert of it. Still, it was not passed because of those query raising that it should be handwritten only, and so some can you throw some light on this, sir?
Let me clear that point also. In very famous case of RG Stone Hospital versus Vinod Agarwal was HIV positive patient. And due to his HIV status, many hospitals refuses him to admit and to go for surgery. He had some urological problem. Ultimately, RG Stone Hospital was ready to get him admitted. Consent was taken in pre-printed form. He was operated. Post-operative events were uneventful. He was discharged in due course. Even then, he filed a complaint against hospital that my consent was taken on pre-printed form, and to take consent in pre-printed form is unfair trade practice. And unluckily, National Commission Delhi decided case in favor of patient, and compensation of rupees 10 lakhs was awarded in favor of patient. RG Stone Hospital was ready to pay that amount, but at that point of time, we were preparing this uniform consent. So one of our colleague, Dr. Nikhil Datar, he was known to this RG Stone Hospital. He approached RG Stone Hospital management and he convinced them to prefer appeal in this particular case. Because if they were not ready to prefer appeal, any appeal was not done, then it would have been compulsory for us to take consent in handwriting of patient only, or in handwriting of surgeon only, or in handwriting of assistant only. And can you imagine how difficult it would have been? So RG Stone Hospital was ready. We preferred appeal. At the time of tabling this appeal, our argument was, what is unfair trade practice? Any unfair means to promote business is unfair trade practice. In our medical practice, if we take consent in handwriting of patient, or if we take consent in handwriting of surgeon or assistant, does it enhance our medical practice? No, court was convinced. So there is no increase in practice if we take consent in writing and not in pre-printed form. So court was convinced, and that order is stay as on today, and case is still on. We are very much hopeful that we will win this case. Until then, we can very well use pre-printed form.
Thank you, sir.
Thank you, sir. Sir, with your permission, can we start with the panel discussion, sir?
Oh, yes.
So, can we have the panel discussion CVs, please? Nikhil ji? So now we move to our last session of the day, and it's going to be the most interesting session with Dr. Asha Jain ma'am being the moderator. It is the panel discussion on case scenarios in bleeding during pregnancy. And it's my proud privilege to introduce our moderator, Dr. Asha Jain ma'am. Ma'am is the chairperson of the Food, Drug and Medico-Surgical Equipment Committee of FOXY and the director of SMSA Hospital Raipur. Ma'am, we welcome you as the moderator of the session.
Thank
And
you.
uh, it is my proud privilege now to introduce and invite as the experts for the panel discussion. Our first expert is Dr. Meena Armo, ma'am. Ma'am is the professor and head of department at Government Medical College, Raj Nandgaon, and is the past president of the Bilaspur Obs and Gynae Society. Welcome, ma'am. Next expert is Dr. Shalini Jain Agarwal, ma'am. Ma'am is the director and consultant at Swabhagya Mother and Child Hospital and secretary of the Raipur Menopause Society. Welcome, ma'am. We are also privileged to have a distinguished panel of senior colleagues with us as the panelists for this panel discussion. And I will just briefly introduce and invite all of you. So our first panelist is Dr. Anjana Chaudhary, ma'am. Ma'am is the secretary of Bhilai Obs and Gynae Society. Next, please. Dr. Monica Pathak, ma'am. Ma'am is the president, Raipur Obs and Gynae Society and the consultant director at Sai Sushruth Hospital. Next, please. Our next panelist is Dr. Jofi Chaku, ma'am. Ma'am is a consultant gynecologist
तो
at
नहीं है
Dr.
भाई, कहीं
Jofi
निकलते हैं तो
Women Clinic and Ashoka Super Speciality Hospital, Raipur. Welcome, ma'am. Our next panelist, Dr. Prabdeep Kaur, ma'am. She's the Chief Consultant Obstetrician and Gynecologist at Jawaharlal Nehru Hospital and Research Center at Bhilai. Dr. Anushri Padgaonkar, ma'am. Our next, please. Yeah, Dr. Anushri Padgaonkar, ma'am. Ma'am is the Clinical Deputy Secretary of the Bilaspur Obs and Gynae Society and the Director of H2O Care Super Speciality Center at Bilaspur. Welcome, ma'am. Our next panelist is Dr. Anuradha Chaudhary Tibrewal, ma'am. She is the Secretary, Raipur Obs and Gynae Society and the Director of MMR Hospital and IVF Center at Raipur. Dr. Rashmi Sood Vats, ma'am. Ma'am is the Joint Secretary, Raipur Menopause Society and the Director of Guru Kripa Nursing Home. We welcome you, Dr. Rashmi. Next, please. Dr. Sunita Kanoi, ma'am. Ma'am is the treasurer, Raipur Obs and Gynae Society and a consultant at the Shaswat Hospital, Raipur. Next, please. Dr. Ankita Goyal, ma'am. Ma'am is the consultant obstetrician and gynecologist and laparoscopic and hysteroscopic surgeon at the Sankalp Multi-Speciality Hospital, Ambikapur. Our next panelist is Dr. Neha Thakur. Ma'am is the Associate Professor Obs and Gynae at the GMC Hospital, Mahasamund at Chhattisgarh. And our last and our next panelist is Dr. Saurabh Bithare, sir. He's the consultant gynecologist and ultrasonologist at Bithare Nursing Home and Maternity Hospital, Champa. Our next panelist, Dr. Rupali Verma. Ma'am is a senior consultant and director of obstetrics and gynae at RS Lawley Clinic and Diagnostic Center, Raipur. And last but not the least, Dr. Kirti Nanda, ma'am. Ma'am is a secretary, Raigad Obs and Gynae Society and a senior consultant and IVF specialist at the Rajpriya Hospital, Raigad, Chhattisgarh. We welcome all our esteemed panelists, and I hand over the session to Dr. Asha Jain, ma'am, to start the panel discussion. Thank you, ma'am.
Thank you so much, Dr. Deepika. And am I allowed to share my screen?
Yes, ma'am.
Yes, ma'am. By the time the panel ends, almost everyone has left. So I want to start by expressing my gratitude to Dr. MC Patel, sir. I worked with him for more than 100 sessions of Happy Masterclass. And because of that, I got to know everyone, and he has helped me a lot in my elections. I request all of Chhattisgarh, if possible, Chhattisgarh and Madhya Pradesh, those who are present here, please do support him for his election. Everybody has been praising him that he helps everybody. He's there for everybody. But now it's payback time. I feel that we need to actually put what we say into our actions. Let us all go ahead and support him. With that, I will start my presentation. So, as usual, Shri Ganeshaya Namah. Though this is nearing the end, but I would still say Shri Ganeshaya Namah and start the session. I would request my panelists, would you please put on your videos, and one by one you can answer. At the end of every case scenario, I would request my experts to put in their words. So we are going to talk of evidence-based management and clinical dilemma, navigating the gray zones. Dr. Neha, if you would please mute yourself. So we have heard 3 lectures on antepartum hemorrhage. We've heard first trimester, second trimester. We've heard third trimester. We've heard legal. What can go wrong? Now let us discuss what actually happens, gray zones, where everything is not simple black and white. What decision do we take there? So all my panelists, everyone has been introduced. We are going to go beyond the textbook. We are going to discuss areas where guidelines don't give us the complete picture. We want to implement recent research into practice. We are going to standardize the bleeding severity scale and prioritize maternal vascular health beyond the delivery suit. Because APH, we have had 3 lectures. Nobody has gone beyond delivery. There is the 4th trimester, and then there is beyond. Because a woman, her pregnancy is not the end of her life. Things that happen in pregnancy have an impact on her life in the future. So that is also what we are going to discuss. Less than 15 ml spotting. These are the 2026 guidelines. That less than 15 ml, it can be an outpatient transvaginal scan. You have to confirm the RH status, as Tabassum has said. If it is between 15 to 50 ml, then it is a minor APH. You have to admit for 20 hours. If the pregnancy is viable, then 4 hourly CTG have to be done, and steroids if it is less than 34 weeks. If it is major APH, more than 50 to 1000 ml, you have to admit, cross-match 4 units, and fibrinogen levels have to be assessed. More than 1000 ml or clinical shock, that is code crimson, tranexamic acid has to be given and immediate delivery has to be done. This is the severity scale. So now we come to the first case, and we have not spoken, none of our speakers actually spoke about aspirin. So our first case is going to be aspirin. A 38-year-old, gravida 1, para 0, an IVF scenario. She is 14 weeks and she's on 150 milligram of aspirin for preeclampsia prophylaxis, which has been started because her uterine artery PI was very high. Now you see her, she comes with bleeding and there is an 8 centimeter subchorionic hematoma. And also there is some active spotting. So externally there is very little bleeding, but there is an 8 centimeter subchorionic hematoma. I want to ask the first question. Does low dose aspirin increase the risk of major hemorrhage in the first trimester?
No, no, ma'am.
No. So thank you, Anuradha, for that. According to ACOG 190, should aspirin be discontinued for minor spotting?
No,
Again,
no,
no.
ma'am.
No.
No.
What is the
ACOG does not
established
recommend.
risk of stopping aspirin in a patient with high risk factors for preeclampsia?
She may even land up in further complications with preeclampsia if we discontinue the therapy.
Okay.
They,
So
ma'am,
If
there may be
we are
increased risk of early onset pulmonary embolism, fetal growth restriction, preterm births, and placental insufficiencies. So there is
no,
high
the
benefit.
question is, if you stop aspirin, what can happen?
Ma'am, this
The
will
question
increase
is
the
not the
relative.
complications of PIH. The problem is, if you have stopped aspirin for a 8-centimeter hematoma, then what happens?
The risk of early onset preeclampsia and placental insufficiency will raise significantly.
Agreed.
risk
Yes.
of that increase.
So, will the hematoma size increase?
No.
No.
No, ma'am.
No.
Does the PRISM trial support the use of progesterone for this patient?
Yes, 400 milligram BID.
Yes, previous miscarriages. Yes,
Dr. Meena, can you dilate a little bit on this trial?
Ma'am, as you have written that definitely it acts on threatened abortion. Yes, bleeding in first trimester, and its dose is 400 milligram BD. Uh, as per the RCOG, NICE says it can be given vaginally for up to 16 weeks, but average 12 to 14 weeks is okay.
So, is there a defined safety threshold for hematoma volume when using antiplatelets?
No, not exactly.
No, ma'am, not exactly.
ma'am.
So, there is no safety threshold. Now, what is the impact of antiplatelet therapy on miscarriage rates in patients with subchorionic hematoma?
It is directly not related, ma'am, to the miscarriage rates. The improvement is there if we carry on the aspirin therapy, especially 75 milligram to 150 milligram. So live birth rates would be higher, but stopping the therapy definitely would lead to the early onset preeclampsia and placental insufficiencies.
What
So,
I feel,
if
ma'am,
there is heavy bleeding, you have
then we
to
have to
restart.
yeah,
You
yeah.
stop it for
Yes.
2 to 3
48
days and then start again.
47
Yes,
to 8 hours. Yes.
So, is there anything my experts would like to add here on this case?
No, ma'am, it's okay.
Okay, so now we go to the second case. Because we've done everything, I've just taken rapid fire questions. This is the second trimester, and the patient has placental bleeding and placenta previa, basically. So the question is, you want her to stay at her home or you want her to be hospitalized in the patient? That is the basic crux of the matter.
She can stay at her home.
What are the RCOG, ACOG criteria for considering outpatient management?
If the
Which
patient
patient will you
is
allow outpatient
stable,
management? Yes, Saurabh?
if the patient is the patient is stable for greater than 48 hours, patient is asymptomatic, and 24/7 hospital transport facilities available for the patient.
There is a rule of 20.
Then we can.
Do you know what that rule of 20 is?
20 minutes to come. 20
Yes. The cervical length should be more than 20 mm. And the patient should be able to come to the hospital within 20 minutes of problem.
Yes.
So there should be vehicle, the road should be empty or she should be nearby, but the transport time should not be more than 20 minutes. Does a grade 4 previa carry a higher risk of sudden hemorrhage than
Yes.
grade 1?
Yes,
Ma'am,
ma'am.
along with that, we have
Yes.
to.
Yes.
Yes.
Yes, yes. Ma'am,
And
what
grade
I
4
want to add
placenta.
here, we have to also exclude along with placenta previa. Is there any history of cesarean section? Any chance of morbid adherent placenta? If no risk
We will
factors,
come
then
to
we can
that.
leave.
Wait. We will come to that.
Okay.
We will come to that. So a grade 4 previa has a higher risk of sudden hemorrhage compared to 1?
Yes.
Yes.
ma'am.
Is hospitalization for stable previa able to reduce neonatal mortality? You
No.
hospitalize the
ma'am.
patient.
No.
No, ma'am. Mere
No.
hospitalization for all stable previous patient will not reduce neonatal mortality.
Okay. So is there any role of pelvic rest?
Yes, ma'am. Yes, ma'am.
The avoidance of mechanical trauma basically from intercourse.
Any strenuous physical
Intercourse,
activity should
yes.
be avoided.
What exactly is pelvic rest?
Avoidance of
Sexual intercourse.
Vaginal examination, no vaginal examinations.
Okay.
No intercourse.
Any
What
heavy
is
physical
mandatory
activity?
distance or time requirement for home management?
It should be
As
less
per
than 30
to
to
20.
45
Less
minutes.
than 30 minutes.
30 to 60 minutes should be there.
Less than 20.
Less than 30
20
minutes.
minutes.
20
20
already you have
20.
told.
Not 30 to
20
60.
minutes.
20 minutes.
20
How
minutes.
many Herald bleeds are typically seen before a major hemorrhage?
No correlation in regarding this. Sometimes the first episode can be very major, and sometimes there can be multiple small episodes before the major outbreak.
And
Agreed.
ma'am, not all major hemorrhages are preceded by multiple minor bleedings.
And even
So Herald bleeds have no role to play.
no role. And even, madam, if there is a major degree of placenta previa and there is no bleeding, means it is a very high suspicion that it can be morbid adherent placenta.
So do you want the patient to have steroid? If she has come
Yes,
for
definitely,
bleeding,
ma'am. Yes, ma'am.
Yes.
Yes.
it's the wrong answer.
If we
Because
are anticipating the delivery within a week, then the steroids have to be given. If not, the steroids are supposed to be not given.
exactly. So she is 32 weeks, total placenta previa. 7 days back, she had a minor bleed. She lives 20 minutes from the hospital. So you want to give her steroid? No.
I will say, madam, we should give because we don't know when she will land in the heavy.
That is against the guidelines. That is totally against the guidelines because if you give steroids and the patient does not deliver in a week, there are different problems with the neonate. The
Ma'am,
patient should deliver, and in previa, you don't even have to wait to give steroids to deliver. That is the guideline.
Ma'am, I would like to add something.
Yes.
If 1 week pass, then we can give second second rescue dose. So if patient comes at 32 weeks, then as we said that asymptomatic patients, we can wait up to 36, 37 weeks in case of placenta previa. So we can give second rescue dose after that, but not more than 3
Actually,
as per the.
it is not as per guideline. Unless you see a short cervix, unless you expect delivery in a week clinically.
Ma'am, it is given in different guideline actually. It's not in placenta previa or pass, but it's in preterm.
No, but this is not preterm, right? This is not preterm. This is basically.
Yeah, but we are planning for
No.
preterm. We are planning for preterm delivery or cesarean. That's why we
You
can
are
give.
not planning. She's not bleeding, right? She's stable.
Yeah, okay.
She's stable. She lives
Right.
20 minutes from the hospital. She has grade 4 placenta, but the cervix is long. There is no problem at all. So will you give her steroid, yes or no?
Yes.
Again, that is against the guideline. Whoever says yes, but it is against the guideline. So does cervical length predict an emergency delivery?
Yes.
Yes, there is likelihood of preterm. delivery.
The same
If it is less than 25
less
mm.
than 2.5 centimeter is crucial.
Okay. Now the Fetal Medicine Foundation says it is 2 centimeters.
Okay.
Yes.
Less than 25 mm, there will be bleeding. Now we come to the third case. 35 weeks, Gravida 3, Para 2. Sudden rupture of membranes occurs, followed by a small volume bright red bleeding. The mother's vitals are all stable, but the fetal heart rate is suddenly 90 beats. What do you suspect?
Vasa previa.
So, why is the fetal heart rate the primary indicator of severity?
Because the bleeding is fetal blood. The bleeding is fetal blood. So there is acute hypovolemia
and hypoxia.
Fetal hemorrhagic shock.
So how much can a fetus bleed before it is gone?
So almost 30%, because it has 80 ml of blood per kg. So if we assume it is 2.5 kilograms, so it will be approximately 180 to 200 ml. So if 30% is gone, then fetus may go into stillbirth.
So 30% means what? 60 to 80 ml.
60 to 80.
Okay, so it's 60 to 80 ml blood loss is enough to kill the fetus. So what is the sensitivity of prenatal ultrasound for Vasa previa?
It's almost 95 to 100% sensitivity. Specificity is 99%. And it has a almost 100% predictive value for Vasa previa.
Agreed. But in all our practices, there are 15 people here. Tell me, how many of your reports contain the insertion of the umbilical cord?
None, ma'am. I have not seen any.
So then if nobody is reporting, then what? Theoretically, yes, they should be reported. But is it reported? Have you seen it?
Practically not.
Practically not. So it is sensitive, but it's just not done. And we need to ask for it. So how quickly can a fetus exsanguinate in a Vasa previa rupture?
Within
50 to 60 ml of blood.
Within minutes.
So actually, there is here. Do you want to do the APT test to have to manage fetal bradycardia?
No.
Now,
No,
if
ma'am,
the Vasa previa is diagnosed in the prenatal period, does it improve neonatal survival?
Yes.
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 Not.
Yes.
Yes, you will prepare.
Yes, it is.
So is color Doppler for patients with low-lying placenta recommended?
Yes.
Yes, ma'am.
Yes, it's recommended.
It is recommended.
Every patient.
Now, would you prefer to do a cesarean section for a classical cesarean for Vasa previa?
No, ma'am.
No.
Lower segment transfer.
Think. You have an anterior placenta with Vasa previa.
Ma'am, if previous scar is there, or if we suspect like it's overlying previous scar, it's the preterm section where lower segment is not formed. We can go for the classic. We can go with the classical approach.
Means the question is Vasa previa. You want to operate before the patient goes into labor, right?
Yes.
Simple. So you are waiting 36 to 37 weeks. So the lower segment is formed, but the membranes are there and the Vasa previa is there. Do you want to do a classical cesarean or you want to do a conventional?
Classical is not exactly required.
Classical incision.
We will give low incision, and lower segment cesarean section will be the only, transverse incision will be the only required thing. But we need to be conscious, and if possible, we can deliver the baby in cowl without rupturing the membrane. if vessels are
Yes.
not visible, and then very cautiously, just above or by the side of the vessels, we need to puncture so that fetal blood does not
But
loses.
maybe it might be required, but mostly we are able to do it by a low segment. So what is the primary cause of fetal death here?
Is the
Fetal
fetal shock. It's the fetal
hypovolemia,
hemorrhagic
fetal
shock.
Fetal
hypoxia,
hemorrhage leading
Is
to
fetal shock. Yes.
MC
hypovolemic
Patel sir
shock.
still here? Sir is still here. May I ask him a question? Patel sir? A scan was done at 36 weeks. Okay, vasa previa was missed. The doctor, in all good faith, did an ARM at 38 weeks and a stillbirth occurred. Right? Now, who gets the blame? Is the sonologist to blame or is the gynecologist to blame?
Hello.
Yes, sir.
Yes. Am I audible?
Yes, sir.
Yes, sir.
Yes. So what was the question?
The question is that an ultrasound scan was done at 36 weeks. Vasa previa was not reported, but it was vasa previa.
Yes. Yes.
Now the patient came in labor and the doctor did an ARM. There was fresh bleeding and then there was a stillbirth. Now,
Yes.
who gets the blame? The sonologist or the gynecologist?
So for the sake of blaming, a patient may blame both. But in court of law, how we have to go with? Say, for example, if there was a report from a sonologist, there was no mention about previa. I mean, vaja previa. So,
Yes, sir.
if he would have mentioned, then I would have managed case accordingly. That could be one argument on part of gynecologist. But as far as straightway to the allegation to gynecologist, though report was not mentioned, but at the time of your clinical examination or so, was it possible to diagnose vaja previa? So
If
that
you would
question,
have done a transvaginal scan, you would be able to diagnose it. But
yes,
intrapartum ultrasound is still not the point of care in our country. It is not.
yes, and not routine now as on today.
Yes, sir.
Yes. So the question will be there in court of law that was it possible for gynecologists to diagnose before delivering the baby or going for ARM? Because ARM is contraindicated in case of vaja previa, all we know, and it
Yes,
will
sir.
be hemorrhage and ultimately just happened in this case IUD. It is very common stillbirth. So in this situation, this allegation could be there.
No,
That
but
was it
who
possible
can
for?
defend? Can the gynecologist defend herself?
Yes, yes, gynecologist will defend. I mentioned prior also. Gynecologist will defend that report from sonologist was normal. He didn't mention anything about possibility of vaja previa. So relying upon the report and considering the condition of patient, I straightway went with ARM.
Sir,
So
I want to be the devil's advocate here.
yes.
Okay, now you've done it. That you didn't mention. Can the court ask, did you specifically ask for the position of the cord in your requisition for ultrasound?
No. In ultrasound report, usually if it is for advanced scan, the sonologists usually mention that it is advanced scan. So in advanced scan, they are
No, sir.
supposed to do all
My
this.
question is that should a gynecologist ask for the cord insertion in her requisition? Because if you have not asked and they have not given, then it doesn't matter. You've just written growth and Doppler.
So, if gynecologist has mentioned, then it becomes a compulsory for sonologist to mention about report of insertion of cord, etc. If he has not mentioned, then also sonologist cannot have excuse in eye of law, I would say, because once you go with sonography in detail, then you are supposed to mention everything about baby, about placenta, about cord, about liquor. So one cannot have excuse that gynecologist didn't ask for.
Okay. So gynecologist is safe, but I would still say that if we want, we are the ones who face the patients and their
Yes.
families. So we should
Ne-
actually ask for cord insertion.
Yes. If we have mentioned, then it is very specific thing we have asked for, and sonologist will come up with report.
Thank you, sir.
Yes.
Now we come to the fourth case. Am I going too slow?
No, ma'am,
34
it's okay.
weeks, dark bleeding, uterine tenderness, and the ultrasound is negative for retroplacental clot. You don't see any clot.
Abruptly.
What is the sensitivity of ultrasound in diagnosing placental abruption?
Only 50%.
50%.
50%.
Okay. So why is fibrinogen a more sensitive marker than hemoglobin in acute abruption? Why? Yes, Jofi?
Immediately the consumptive coagulopathy happens, and because of that the fibrinogen level reduces, so that is more sensitive than the other parameters.
So if it is less than 200 milligram per deciliter, then it is a very high risk.
Okay. So what fibrinogen level is a trigger for massive transfusion protocol?
Less than 2 gram per liter.
Less than 2 gram, less than 1.5
मैं
grams.
अपना ब्लूटूथ ऑन कियो.
Less than 200 milligram per deciliter.
Less than 200 milligram.
Okay. Now, if there is unexplained APH with reactive CTG and stable maternal vitals, what are you going to do?
We will admit and observe the patient.
Expected management.
Fibrinogen levels have
And
to be
more.
seen.
With
She's 34 weeks.
Expected management, ma'am, with measurement of fibrinogen level.
And how often do you want to do your CTG?
Every 4 hourly if you are
4 hourly.
suspecting
4 hourly.
DIC.
For all CTG.
Now, the ultrasound has not seen any bleeding, but there is bleeding. So, would you give DEXA, yes or no?
Yes, yes.
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 If there is a cuvellaire uterus, this is for my experts. If there is a cuvellaire uterus, how would you manage that during surgery?
Yes.
Meena? Shalini? If there is a cuvellaire uterus, how would you manage it?
Hello.
Yes.
If there is no atonic PPH, then we have to observe and
No, it's a cuvellaire uterus. Means it's a wood-like
yes,
consistency.
but it is well contracted. But it is well contracted, and if it is, that hemoperfusion on the myometrium is not very much. If it's in a mild form, there is nothing else we have to do. But in case if there is associated atonic PPH and devascularization, steps which we take for PPH, we have to take. And ma'am, one more thing I would like to add, that if there is continuous bleeding, then we have to give this fibrinogen 12 to 15 milligram per kg body weight, and till the level goes above 2. And the maintenance dose which we have to we have to achieve is HB. HB should be more than 8 gram%, and platelet should be more than 75, and last is fibrinogen level, that is more than 1. It's not 2, ma'am, in case of APH. But in case of PPH, it is more than 2. It should be more than 2.
In APH
So as
also
per
it
the
is 2. It is 2. Okay.
Okay.
Is there a long-term cardiovascular risk associated
Yes.
with APH?
Yes. High risk of a stroke. In the coming decade, the
Risk of
patient can
CVD
develop
later in 20 years.
cardiovascular.
Okay, so how many of you call your patients back after 6 months?
We call.
We call. But
How
they
many
don't
come?
No, nobody comes.
No.
Very few.
How many of you
Few of
write
them
on your
come.
paper to review in 6 months?
Yeah, that we right. Actually, general protocol, ma'am, what I am following is like once we do the discharge, then we call for suture removal. Then after that, within 1 month, we call for another follow-up. And then that prescription I write for a 6-monthly follow-up. Provided that if she loses the compliance, at least the documentation is there that we ask them to come back.
See, this is the guideline. Fibrinogen levels less than 200 milligram deciliter indicate severe consumption and 100% positive predictive value for severe abruption. And we want to maintain it above 2 because in pregnancy, the levels are above 4 normally. So when it is 2, it is already high risk. Now we come to the pars and ectopics, Anuradha's favorite subject. There is a suspected placenta percreta involving the bladder or a cesarean scar pregnancy. If there is placenta percreta, what is the gold standard surgical approach?
Hysterectomy.
Hysterectomy.
Classical.
Classical C-section.
Classical C-section.
What I feel, ma'am, if patient is not bleeding, everything is stable, leave the placenta. It doesn't matter.
Hmm.
And
So,
do hysterectomy.
in
Leave the placenta in
go
situ
for
and do hysterectomy.
Madam, gold standard
Gold
is
standard
hysterectomy.
surgery. Yeah.
yes, gold standard is?
Hysterectomy.
Surgery. Hysterectomy.
Hysterectomy.
No, Dr. Meena Armo gave you the correct answer. The
If
guideline
patient is
is
stable,
that you just remove the baby and leave the placenta in situ
as such.
as such. And after 6 weeks, plan for a planned hysterectomy. That
Yes.
will reduce blood loss by more than 2.5 liters. You should not do a hysterectomy at the same time.
And in
Now,
fact, madam, we may not go for hysterectomy. We have to follow up. And if you need, we can give methotrexate. And if required, we can go for curettage and follow up the patients. You should not land in secondary PPH and infection, sepsis. These are the two things. And I have my own patient, ma'am. After 4 months, the placenta is calcified, and within 6 months, he again conceived.
okay. Okay. Now, there is a triple therapy for cesarean scar pregnancy. How is it different from systemic methotrexate?
It has a better
What do you do in a triple therapy? And what do you do in a systemic methotrexate?
Triple
It's
therapy, local
methotrexate plus
methotrexate.
balloon therapy and aspiration.
Balloon aspiration, yes.
Triple therapy is not methotrexate. It's a P3. P is there, pre-evaluation, and then pelvic devascularization. And last is placental non-separation with myometrial excision. So it's kind of conservative surgery.
No. Triple therapy for CSP ideally
CSP.
is what he was saying.
Okay.
That is, you
Madam,
do a
okay, I got it.
transvaginal scan, put
Yes, it's a
methotrexate
cesarean
in the
scar.
sac, and under ultrasound guidance, do a suction evacuation.
Ma'am, it depends on the type of CSP. I mean, it's exophytic or endophytic. If it is endophytic, then we can do suction evacuation. But it is outside the scar towards abdominal cavity. Then local infiltration of methotrexate along with systemic or excision of surgical excision, surgical removal of that sac could be possible. But best one is it depends on the HCG level, beta HCG level, and the size of the sac. I mean to say.
What is the
On
primary risk of conservative management in a cesarean scar pregnancy?
It can be bleed massively, and
Rupture,
sometimes
rupture,
rupture
madam.
can happen.
Rupture, yes, rupture.
Emergency hysterectomy has to be done.
So, in a case of PAS, should internal iliac artery balloons be routinely used if the facility is available?
It's controversial, ma'am. It's not any like indicated that it should be routinely used.
Okay. Does the presence of bladder invasion on MRI necessitate a urologist?
Yes.
No, madam.
Yes.
It's
Yes.
better,
Yes.
sir. It's
We
better.
can manage.
Better to involve.
Yes, a
Yes.
multidisciplinary approach has to be
Approach
taken.
One
should be
thing
taken,
is,
yes.
there are two legal questions here. Is it necessary or is it more convenient? Two different things. It is necessary to have a urologist?
No.
Medico-legally, yes.
Ma'am,
It
medico-legally,
depends on
yes,
how
because
much
if some
area of bladder is involved. It depends on how much area, how much thickness of bladder wall is involved. Then.
Exactly. What is
Should
the
I speak
success?
something?
Yes, sir.
Yes. If urologist is available nearby and if you involve, it's fine. But if urologist is not available, gynecologist can deal with the situation accordingly. Legally, you are safe that way. Because in curriculum of OBGYN, we are taught how to deal with this type of complication related to bladder. Injury to bladder, then suturing of bladder, etc. So it is taken into consideration in court. But it is always advisable to call urologist if it is available near.
What is the success rate of uterine sparing surgery in PAS?
Very good.
See,
It's
I
quite
just
selected
Depends on
properly.
the
Selection.
have you seen Dr. Mahesh Gupta sir operating?
Yes.
Yes.
And
The
even in PGI Chandigarh, now they do PAS cases where they do not open the bladder. Even if the placenta has invaded into the bladder. With very thin sutures, they lift the peritoneum and painstakingly tie each blood vessel.
each blood vessel, yes. Yes.
And once all the blood vessels anterior are tied, then there is no issue at all. Okay. So, is a fundal incision preferred to avoid placental bed in PAS? Obviously,
Yes.
yes. Now we come to the last one. This is of ethics, the viability tipping point. Sir, आप हैं ना अभी? 23 weeks, 4 days pregnancy, major placental abruption, mother is hemodynamically stable, but fetal heart rate shows persistent decelerations and distress. According to FIGO 2024, what is the limit of viability in modern tertiary centers?
25 to
23 to 24 weeks.
Yes, say, but it is 25 to 26 weeks.
Yes, what is the consensus?
23 to 24 weeks.
But
You have a 23 weeks, 4 days.
Yes.
Okay.
there is a difference in viability just as the 24 weeks crosses.
So, what is the estimated survival rate for a neonate born at 23 weeks? What percentage of babies are going to live?
Half
only
of them,
40% babies are going to live.
40,
6 out of 10 will die.
And
So
half of them
60% will
have
die and 40% will live.
Yes.
What is the incidence of severe neurodevelopmental disability in a 23 weeks?
25% will have severe neurodevelopmental disabilities and sensory neural issues like deafness or blindness. Out of those 4, 1 will have this severe things, severe complications.
So basically only 40% are
25.
going to live. Out of
Yes.
those 40%, 10% are again going to have extreme disability.
Yes.
Exactly.
Right. Now,
Mm.
you would have to do a classical cesarean here. The lower segment is not formed only. You cannot do a lower segment section. Now, having a classical cesarean at 23 weeks, does it impact a woman's future reproductive risk?
Yes, ma'am.
Completely. Completely. Completely.
So,
There is
what is
high.
the statistical risk of uterine rupture in subsequent pregnancy after a classical cesarean?
Maybe theoretical risk may be 10%, but it is
20%.
high for all practical purposes.
Does FIGO recommend maternal priority in cases where fetal survival is highly uncertain?
Yes.
Yes.
Yes. Are you going to give magnesium sulfate at this age?
Yes.
Yes. For neuroprotection.
How does shared decision making apply when maternal surgical morbidity is high? My question is here, there are two questions. Will you go ahead and do a cesarean section?
No.
No, not straight away. We need
We
to ask the
will
parents.
Will you
always
do a
discuss with the
cesarean section knowing that you are going to spoil her future reproductive capacity? And also the baby has a 70% chance of not making it properly. Would you still go ahead and do a cesarean
No,
section?
we will not do the cesarean.
But we will always involve the patient's family in the decision.
So I want this answer from each and every one of you. Those I can see on the screen. Rashmi, cesarean,
We will
yes or
allow
no?
the vaginal. We will try to do vaginal delivery because the chance of fetal survival and outcome also is not so good. So we will try to save the future fertility of the patient instead of saving the baby. So we should try more of vaginal delivery instead of doing cesarean section and saving that 23-week baby.
Anushri?
Yes, ma'am, we'll definitely involve the parents in decision making because it will definitely spoil her chances of having a good live birth next time. So we need to tell them that this 23 week is already means it, although it is salvageable, but the prognosis is not very good.
Okay. Shalini?
Yes, madam, we will not do, even few guidelines recommend that you may do cesarean section, but for all practical purpose, we'll try to do vaginal deliveries because there are high chances of defective neurosurvival development of the baby. And we will share everything with the family, like what is the palliative comfort focused management of the baby, what is active survival focused management of the baby, and it may ruin the maternal obstetric capacitance in the next pregnancies also. So we will
Anuradha?
totally discuss everything with the family.
Anuradha? Disappeared. Kirti?
Ma'am, in my case, I will prefer to share everything with the patient and her family members, and then take a share consent. As far as vaginal delivery is concerned, I think the patient is heart rate is deceleration, and in the patient, she is not in labor. So vaginal delivery will take a much longer time, and during the delivery that might have been IUD. If the patient party prefer neonate over the maternal thing, then cesarean is a better one. But everything should be in consent, written consent.
Dr. Rekha?
Ma'am, in my opinion, if pregnancy is very much precious after very long duration of marriage and patient's family wants and patient wants, we can try after written consent and we can opt.
Saurabh?
And
You are
good
muted.
nursery care.
Saurabh, you're muted.
Ma'am, patient is hemodynamically stable, then we should try for normal delivery in this case actually. Fetal part is secondary. We should concern first about the patient and her future outcomes, obstetric outcomes and this. We should counsel in such a way to patient that patient is hemodynamically stable and we should try for normal delivery, ma'am.
Okay. Sunita?
And we have to see for the age of the patient, her obstetric career. And as madam told, if it is very precious and she is very high, like late age, then we can counsel her, and it has to be a shared decision. Like we will say the baby is not very much salvageable, but still we have to make a shared decision with the patient. And normal delivery, it is like abortion only, because in normal delivery we are not going to salvage the baby at 23 week and 4 days. And so
That is what, na, because the chances of
yeah,
salvage are only 30%.
yes,
But it is guaranteed that her future obstetric life will be spoiled.
right.
And we also know, ma'am,
Ma'am,
that
if patient
23
is in shock and her vital
uh,
status are very
no,
bad and cervix is, I mean, unright, then we have to do cesarean.
Anuradha?
Ma'am, I feel we have to explain pros and cons of both the side, then balance the things what the patient want, then we have to proceed. Because if pregnancy is precious and a good NICU care is there, we have to explain the what are the disadvantages of delivering a preterm baby and what are the conditions you may suffer. But still, if they want to get a live baby, if they want live baby, then we have to go cesarean section, not other than vaginal delivery. We cannot
But the
give
thing
the
is,
live
for a
baby.
live baby, your counseling, before I end, I would like Dr. Meena, I want you to just give your thoughts on this.
Ma'am, as I already said that we have to see the patient condition, because in this case she is already in major place abruptio. So is her vitals are stable, uh, uh, vitals are stable or not? Then what is the fetal condition? Because in major abruption, I think already fetus is jeopardized. So we have to depend. It all depends on the scenario. Like in your NICU is very good. Like in our case, and I am not much dependent on NICU. So uh, because it's 23, so you have to see the patient's condition, her requirements, her I mean, you have to prioritize the thing. Mother is important or fetus. So it all depends on the scenario. But guideline, whatever guideline says, we have to follow. Ma'am, two things I wanted to add, that we didn't discuss about thromboprophylaxis, because in it's a case of whatever we discuss is obstetric emergency kind of. So when there is blood loss more than 1000, we have to see the score of for thromboprophylaxis.
I have
And
not
in case,
actually taken PPH because all that has been covered in the lectures. I just took what
ma'am,
was the lacunae.
in
That's all.
ma'am, in case of abruptio also, we have to check the blood loss. So thromboprophylaxis, and last one, which is NTD prophylaxis, NTD heart test.
That's
So
already that's been covered. Anti-D and even fibrinogen less than 2, you just have to deliver that patient. Simple.
yeah.
Asha Didi, permitted, can I add one
Yes,
point here?
yes,
I
you
am
are
not a
welcome.
panelist, but I am listening, and many good points you brought out and all the panelists brought out. All the other things are already discussed. In any case, of they have been deferred for the cesarean, and but in any case, if you need to take the cesarean, it is mentioned here that LUS is not well formed, and that's why often the classical cesarean is needed. But in our clinical practice,
We
many
used
of
to give
us are
transfers.
doing for the
Transfers.
second trimester termination, and we hardly found any case where we need to go for the classical incision for the hysterotomy
Yeah,
while
but we
removing the
still go
baby.
for a transverse incision only,
So,
but it is higher.
U-shaped transverse incision makes
The things
obstetric obstetric
easy outcome.
obstetric thing little better in the future. In any case, if it is required, first trial for the transverse incision, if required, made J, made U, and likewise. So just this one point, that not always go directly for the classical. In any case, if you need to go in the second
But
trimester
the
section.
incision is definitely higher. It is
Yes.
not classically in the lower uterine segment.
Yes.
But still the
It is the
obstetric
transverse
performances
one. That is
in the
agreed.
future remains better as
Yeah.
comparison to a actual classical cesarean section.
So this is what is the basic thing. Fibrinogen more than 2, Vasa previa, color Doppler for all low placentas, aspirin, don't stop for minor SCH, CSP ectopic triple therapy, and follow-up CBD screening at 6 months in all cases of APH.
Ma'am, NTD 500 is not enough in case of continuous bleeding. So we have to give up to 1500, or it all depend on the Klehr-Betke test. So it is recommended, whatever I am saying is as per the recommended.
Yeah. That is true, but the Klehr-Betke test is not so much available.
Yes, you are right.
That is another thing. So thank you so much.
Thank you, ma'am. It
Thank
was
you.
very,
Thank you, ma'am.
very practical and very good discussion. Really.
Very, insightful and interesting as well. Yes, ma'am.
And I'm very grateful to all our obstetric gynec teachers here who have volunteered and are pitching in. Thank you so much, Jyoti.
Thank you, ma'am. Thank you.
Meena.
It was a very nice panel, and we enjoyed the material said by you.
Asha ma'am's discussion is always enjoyable and
Very
mind
practical.
screening. Whatever, even you practice, sometimes you get confused what to answer.
Yes, yes. You have to update it. If you
Yes.
come to the madam's class, then you have to update it thoroughly.
Yes. Yes.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much. Thank you, sir. Thank you. We all
So,
enjoyed.
many congratulations to Dr. Asha Jain for nicely conducting this panel. And thanks all the panelists for putting their inputs, making this panel very interesting and memorable one. And special thanks to Asha for designing this, helping me to design this webinar. And special thanks to both the speaker, Sangeeta and Tabassum. They have taken our word to continue as a speaker at last moment. So thank you all who have
Thank you,
joined this
sir.
webinar. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you,
everyone.
sir. Thank you all.
Thank you, sir.
Yes.
And we would like to thank our technical team of Corona Remedies for giving us the platform. And it was like a seamless experience. And so thank you so much, Dr. MC sir, for giving us the opportunity. Dr. Monica had an emergency, so she had to
Ma'am,
step
I'm
out.
back. I'm back. I
Okay,
came
अच्छा
back.
तो please, okay, please
So
आप फिर
Monica, we
नहीं,
can
नहीं.
conclude now.
आपके बगैर तो हो ही नहीं
Yes,
सकता
sir.
काम. ठीक है, thank you for coming back.
Thank an official
हाँ जी.
early delivering the vote of thanks. I would like to thank the president and the secretaries of Bhilai, Bilaspur, Raigad, Rewa, and Sigurali societies. We also would like to thank Dr. Ava Singh, Madam, for joining us as chief guest today. Dr. Sarita Agarwal, Madam, as guest of honor. Dr. Trupti couldn't join in because of an emergency. Our speakers, Dr. Sangeeta Sharma, Dr. Tabassum, and Dr. Patel, sir, for giving us an in-depth insight about hemorrhage in pregnancy. Our chairpersons, Dr. Archana, Dr. Padma Shukla, Madam, Dr. Gitika Sharma, Dr. Paulami, Dr. Rashmi Sharma, Dr. Jyoti Jaiswal, Dr. Mehir, Dr. Tibwan Sahu, Dr. Rekha Singhal, ma'am. The cherry on the cake was the moderator, Dr. Asha Jain, madam, who has brought out crisp but very good take-home messages for case scenarios or bleeding during pregnancy. Our experts, Dr. Meena and Dr. Shalini, have given their excellent inputs with our panelists, Dr. Anjana, Dr. Monica Pathak, Dr. Jofi Cheko, Dr. Prabdeep Kaur, Dr. Anushri Padgaonkar, Dr. Anuradha Chaudhary, Dr. Rashmi Sood, Dr. Sunita Khanoi, Dr. Ankita Agarwal, Dr. Neha Thakur, Dr. Saurabh Bithare, Dr. Rupali Verma, and Dr. Kirti Nanda. Last but not the least, thank you, Mayur from Corona Remedies, for the technical help and the academic platform.
Thank you, ma'am.
Last,
Thank you
the
very much.
earnest request to please support Dr. MC Patel sir's candidature for President Foxy 2026, requesting all of you to please vote for sir. Thank you again, sir, for the opportunity to coordinate this event.
Yes, Mayur, we can conclude.
Yes, sir.
Okay, sir.
Good night,
Okay.
everyone.
Thank you very much, sir. Good night. Thank you. Thank you very
Good
much.
night. Good night.